Okay, so good evening, everybody, and I'll hand it over to Dr. Ravi for further proceedings. Over to you, Ravi.
Good evening, everyone. Today we are just all of them have just together for the DOACON 2020, and without wasting time, I just hand over to Dr. Sharad Agrawal, our esteemed DOA president. Sir, please.
Good evening, friends. I welcome you all to the DOACON 2020, the annual conference of Daily Orthopaedic Association. This year, the event had to be organized in a very difficult time when the pandemic is at its peak, and hence physical interactions had to be kept to minimum for safety of all. Dr. Anil Jain, Chairman, DOACON 2020, Dr. Dhananjay Gupta, and Dr. Manish Dhawan, organizing secretaries of the conference, have charted out an elaborate 3 days program, which for obvious reasons has to be largely virtual. A large part of the event has been allocated to paper presentations to provide young as well as senior orthopedicians a platform for showcasing their research work. On the third day, we have discussions on subjects relevant for today's scenario, namely PG training and orthopedic practice under the cloud of pandemic. We all know the life even after the pandemic abates is not going to be same as before. Many protocols shall have to be followed in day-to-day orthopedic practice for a long time. New technologies have to be evolved for optimizing orthopedic care, therefore, hence a full segment has been allocated to futuristic orthopedics. Present scenario may divide us of physical interactions and hands-on learning, but there is a silver lining too. The technology has extended our reach far and wide. A greater number of academic interactions can now be accommodated, which the presenter can share without the need to physically or come physically, and it can be extended to an even larger number of interested listeners across the world. All in all, a great moment in the history of Daily Orthopaedic Association and a commendable effort by the organizers and the participants. I extend my best wishes to all the presenters and organizers for the success of DOACON 2020. Thank you and all the best. Dr. Dhananjay.
Hello, friends. This is indeed a great privilege to be organizing this annual conference of Delhi Orthopaedic Association under the aegis of Delhi Orthopaedic Association. I'm indeed grateful to our president, Dr. Sharad Agrawal, our scientific chairman, Dr. Anil Jain, who unfortunately, because of his official commitments, could not be here virtually also. He has been appointed as the dean of the faculty, medical faculty, and is quite engaged in those official activities as well. So we'll be sharing his message for this conference shortly. This has been a testing time for all of us. I'm not talking professionally or personally. What I believe as an organizer, it has become a different concept, a total shift from where we used to organize our conferences earlier to what has become now. We knew that the presentations, the papers, the scientific work is going to be less. And that's the reason we thought that this time we should go beyond daily. And so we floated the idea, and we have been really, really surprised and pleased by the response which we have received. It was an idea to reach to the residents, to the doctors who are orthopedic surgeons who are outside the India also. But somehow, I guess, we could not get a good response from abroad. But still, whatever response we have got, it's been really heartening. I'm thankful to all the people who have taken keen interest in presenting their work, sharing their knowledge with us. The virtual conferences has got a huge challenges, let me share with you, which we are still grappling with. And I'm pretty sure you must be wondering, the arrangements, they are not proper or whatever. But let me share. The physical distancing, inability to reach, the communication has become so swift, so fast forward that we hardly get time to sit around and think how to plan, how to execute. So that could be the reason why we are facing all these stumbling blocks in this particular process. And I'm sure the way the event, the conference progresses, we should be able to iron them out. Kindly bear with us. And I promise you there's going to be a very, very scintillating and knowledgeable conference. And I thanks once again to all of you for joining us. Now over to Dr. Ravi Chauhan to start with the scientific proceedings of this session. Ravi, over to you.
Yeah, thank you, sir. Before proceeding further, actually, in the absence of Dr. Anil Jain, our organizing chairman, I would like to play the video that sir has sent to us. I'm just sharing it.
Dr. Sharad Agrawal, President, Delhi Orthopaedic Association, Dr. Hitesh Lal, Secretary, Delhi Orthopaedic Association, all executive members, members of the scientific committee, and all other dear all members of Delhi Orthopaedic Association. Thank you very much indeed for giving me this opportunity. Well, as we all know that India and world are passing through one of the most difficult phase, which is a challenge.
There's some problem with the sound. There's some problem with the sound.
We are not getting the sound.
There is a problem in the sound.
Ravi,
Can't hear the message.
Ravi, I think you have to share again with the computer sounds sharing.
Okay, just.
Yeah. So while sharing, click on share computer sound.
Yes, sir. वही कर रहा हूँ, sir. Now I'm sharing with computer sound actually.
Dr. Sharad Agrawal, President, Delhi Orthopaedic Association, Dr. Hitesh Lal, Secretary, Delhi Orthopaedic Association, Sharad Agrawal, President, Delhi Orthopaedic members, members of the scientific committee, Secretary, all other Orthopaedic Association, all executive members, members of the scientific committee, and all other dear all members of Delhi Orthopaedic Association. Thank you very much indeed for giving me this opportunity. Well, as we all know that India and world are passing through one of the most difficult phase, which is a challenge to the human civilization. And this has happened after almost 100 years since the last pandemic of Spanish flu in 1917. Well, the difference in this pandemic is because of the mode of communication and mode of transportation. The spread is so fast that within 3 months, the almost whole world was being affected. And this has produced a lot of devastation to the human life as well as the countries. And that is why a lot of orders were imposed by the government, lockdown and many other activity. And but then medical fraternity has has to fight at all fronts. They have not only fought the disease and contributed.
Your screen is not shared.
Pandemic, but the best part is that during this time, the lot of time is being spent on improving
I think Dr. Ravi got disconnected because of poor internet connection. Dhananjay sir, you can take over. Or Sharad sir.
I think we can play it later once it's sorted out.
Yes,
Dr.
sir.
Vijay, can we start the session?
Yes, sir. We can start the session now.
One of the coordinators can please
Yes,
take
sir.
please.
Welcome you all to the first session of this annual conference. This is a free paper session in Hall A. Just to remind, on the panelist we have Professor Himanshu Kataria, who is Professor and Unit Head in Sports and Center of Safdarjung Hospital. And as everyone knows, the second panelist is Dr. Sharad Agarwal sir, who is the President of Delhi Orthopaedic Association. The first paper will be presented by Dr. Suraj Singh. His topic is on prevalence and determinants of pressure ulcers in spinal cord injury patients in a tertiary care hospital of New Delhi. One reminder to all the participants, please stick to a timing of 6 minutes. There will be extra 2 minutes for question. That will so kindly stick to a timing. Dr. Suraj Singh.
Sir, is it visible?
Yes, it is visible. Just go to full screen.
Thank you, sir. So myself, Dr. Suraj Singh, third year PG student from CIO, Safdarjung Hospital. So my title for the presentation is Prevalence and Determinants of Pressure Ulcer in Spinal Cord Injury Patient in a Tertiary Care Hospital of New Delhi. Spinal cord injury is a life-threatening and debilitating injury, and these individuals are uniquely vulnerable to pressure ulcer development. The overall prevalence of traumatic spinal cord injury per million population was estimated to be 50 to 906. Low socioeconomic status and education is consistently related to the reduced access to quality healthcare. However, it is a preventable condition, and identification of the risk factors can help in possible intervention in prevention of pressure ulcer. So our aim was to determine the prevalence and determinants, and also their association between the socioeconomic status and other determinants in development of pressure ulcers. So we did a prospective observational study among 96 patients in Safdarjung Hospital. All the post-traumatic spinal cord injury patients with Asia grade A between the age group 12 to 60 were included, and incomplete paraplegia and quadriplegia and non-traumatic spinal cord injury patients were excluded. So based on the inclusion exclusion criteria, patients were recruited, detailed history and examination was done, and patient and his family members were counseled regarding the proper care for the patient. Regular follow-up was done and assessment was done at the end of 12 weeks. Socioeconomic status of the patient was assessed using BG Prasad scale. In results, we found that the prevalence was 44.79%, with majority being in cervical patients. In our study, we found that both underweight and overweight individuals were associated with high prevalence of pressure ulcers. We calculated the BMI according to the ICMR guidelines. As we can see that less than 18.5 individuals were around 65%, and the overweight individual were around 72.7%, which developed pressure ulcers. The p-value was 0.035, which was also significant. In education, we found that the pressure ulcer was common in low socioeconomic status, and the p-value was 0.024, which was also significant. Socioeconomic status had an inverse relation with pressure ulcers. We found that socioeconomic level of patients in class 4 were 73.7%, which was quite high, and also it was also significant. So, regarding comorbidities, we found that there was a positive association between pressure ulcers and the spinal cord injury patient, but it was statistically insignificant. So p-value was 0.46. Regarding the level of injury, we found that mostly the patients of cervical injury was prone to development of pressure ulcer. Around 75% of individuals were there with a p-value of significantly with significant p-value of less than 0.001. Regarding immobilization and positioning of the patients, we found that there was a positive association between the occurrence of pressure ulcer and spinal cord injury with a p-value of less than 0.01, which was also significant. Regarding the site of ulcer, we found that the sacral region was the most common involved during the development of pressure ulcers. Other sites also include heel, trochanteric, occipital area, shoulder, back, and buttocks. At the end of 12 weeks, sir, we found that around 67.4% of individuals had grade 4 pressure ulcers, while 7% and 9.3% were in grade 1 and 2 respectively. We also counsel the patient and the individual regarding the use of pressure relieving devices like air mattresses, water bed, and at the end of study, we found that 72.4% of the individuals, who did not use air mattress developed pressure ulcers with a significant p-value of less than 0.001. Sir, regarding the smoking and alcohol, we also found that it was also positive. It had also a positive association with the development of pressure ulcer, as cigarette smoking also plays a role in development of pressure ulcer, as cigarette smoking impairs cutaneous blood flow. So it will it had some role in healing of the pressure ulcer, sir. So we found no significant difference in the various age groups regarding the distribution of ulcers. We in regarding discussions in most of the studies, as compared to like Saunders done by Saunders, Ham, this association between the low socioeconomic, low income and pressure ulcers has been shown. Association of BMI was statistically significant, as also done by the study done by the Ham, Shaheen, Brighto, and other, that the malnutrition is a known risk factors for development of pressure ulcers. So Ban also noticed a higher occurrence of pressure ulcers in diabetics among spinal cord injury patients. However, in our study, it was not significant.
6 minutes, please conclude.
So Gallis, Ellman, and Brand also reported the healthy behavior such as refraining from alcohol, smoking, drug abuse was strongly associated with reduced risk of pressure ulcer. Therefore, sir, in conclusion, the overall prevalence of the pressure ulcer was found to be high, and it was highest in cervical injury patient. Sacrum was the most common site of its occurrence. High BMI, low education level, and socioeconomic status was highly associated with the development of pressure ulcers. Position change, use of pressure relieving mattresses, wheelchair immobilization has a definite role in avoiding pressure ulcers. And there was a positive association between the smoking and alcohol intake and the development of pressure ulcer. No significant relation was found with the age or with any other comorbidities. Thank you, sir.
Thank you. Kindly unshare your screen, please. Any question from panelists, please?
Can I speak? Can I ask?
Yes, sir.
Rajesh. Dr. Suraj, you excellently presented the various factors which can lead to pressure ulcer or promote pressure ulcers. One very important factor I feel is to how do you counsel the patient. I mean, in developing pressure sores, their counseling, their teaching, how to avoid them is very important, right? Starting from the cleaning, hygiene, keeping
Yes, sir. Sir,
uh, just,
we counsel
just let me complete. And
the,
of course the fecal turning and the bed and all those things have to be very clearly told to the patient, because most of them will be staying at home, isn't it?
yes,
So
sir.
that is very variable factor which will be there. Unless you do well, the chances of pressure sores will be very high. What do you think about it?
Sir, actually, we counsel the patient as well as the attender who is going to take care of the patient at home, and we also showed what is the proper technique of too early posture change and use of various pressure relieving devices like air mattress. Uh, we sir use air mattress in our hospitals, but at home, like if the patient is not able to afford these kind of devices, then he or she will be more prone to development of pressure ulcers, sir. So we counsel them with the proper back care, bowel care, and maintaining the personal hygiene.
So that
We
means
should,
this factor was same for everybody. I mean, this factor you did with everybody. You taught everybody, all the patients, on these kind of care, right?
yes, sir, yes, sir. But sir, depending on their education level, their socioeconomic status, when we discharge the patient, that there would be the changes which will be observing in follow-up, sir. Despite our effort, despite our proper counseling, how much of the percentage was even developing pressure ulcer even after our proper counseling, sir?
Right.
Dr. Suraj, if I ask you a nice presentation, could you collect any data on the time frame at which these pressure ulcers developed?
Sir,
You said grade 4 had 60% and all. So what was the time frame at which they developed?
follow-up was done at 4 weeks, 8 weeks, and 12 weeks. Regular follow-up was done, and the data was compiled at the end of 12 weeks, sir.
So this is a 65% data. The prevalence of the ulcer is at 12 weeks. That's what you're saying.
Yes, sir. At the end of 12 weeks.
And this is without any interventional measures, without any preventive measures?
The preventive measures was there, but only by counseling. There was no intervention done from our side, like for the treatment of pressure ulcers like that. So, we are just trying to identify the modifiable risk factors on the behalf of the patient and his family members.
Yeah.
So they can prevent it on the local level. Sir.
Thank you, Suraj. Next presenter is Dr. Anand Krishna. He will be talking on management of chronic tendinoeclastia by various surgical techniques. Dr. Anand, are you there?
Yes, sir.
Please share your screen.
Please share your screen, Dr. Anand. Yeah, put it on presentation. Yeah,
Yes, sir.
Go ahead.
Can you see it, sir?
Yeah, go ahead, please.
Good evening, everyone. This is Dr. Anand. So my topic for the presentation today is management of chronic Achilles tendon tear and by various surgical techniques. So in the introduction, the Achilles tendon, it is the largest tendon in the body which receives fibers from the soleus and the gastrocnemius muscles. And it is quite a common type of a sports injury. The most common cause of injury is sudden plantar flexion or dorsiflexion of the ankle, or by forced dorsiflexion of the ankle outside of its normal ROM. And around 20 to 25% of the acute ruptures remain initially undiagnosed, but later on these patients generally come to us if they have decreased ROM or a physical disability. And earlier in around Before the 1930s and the 1920s, the management of these type of injuries were generally conservative by strapping and bracing, but later on, surgical procedures were developed. So in our study, we compared 3 surgical procedures, and amongst these were the Krakow technique, the gastrocnemius soleus complex, the VY myotendinous advancement, and the turn down flap technique of the gastrocnemius. And there are other surgical techniques also, including tendon transfers of the peroneus brevis, the flexor digitorum longur, and the FHL. In totality, there is a lack of consensus on the best management of chronic Achilles tendon rupture. Hence, this study was planned to compare the post-operative clinical improvement among the various surgical modalities for AT rupture. In the materials and methods, our study included 22 cases of chronic tendo-Achilles rupture, and they were treated either by the Krakow technique or by the VY tendinous advancement or the gastrocnemius soleus turn down flap. And the period of the study was 2 years, from July 2015 to July 2017. These patients on admission, a detailed history of these patients were taken and collected on a pre-structured questionnaire, along with clinical examination, X-rays and ultrasounds and MRIs. And we evaluated the ankle function based on the Carlson and the Peterson scoring system. We included all the patients above 18 years of age who had chronic and complete rupture, and there was closed injury, and we excluded any compound fracture patients and any patients with vascular injuries. In the post-op evaluation, the ankle was kept in plantar flexion using a above knee cast for 6 weeks, and static exercises of the hamstring and quadriceps were started from the second post-operative day. And the plaster was removed after 6 weeks, and partial weight bearing was allowed. And after 12 weeks post-operatively, the patient was allowed to walk full weight bearing without support. And after 1 year, the patient was allowed to start running or jumping or jogging. In the statistical analysis, the functional outcome in terms of the Carlson and Peterson scoring systems, plantar flexion and dorsiflexion were measured pre-operatively and post-operatively, and regular follow-up was done at 3 months, 6 months, 9 months and 12 months. And they were statistically measured by the repeated ANOVA technique. So in these 21 patients, the MRI was done to measure retraction also. And with patients which had less than 2 centimeters of retraction, we used the Krakow surgery. For 3 to 6 centimeters of retraction, we used VY plasty. And for more than 7 centimeters, we used the gastrocnemius soleus turn down flap. So this is a graph of the mode of injury, maximum being patients of the blunt trauma, and then by the motor vehicle accidents and twisting injury. So this is the statistical analysis of the Krakow surgery, and in which we can see that the Carlson and Peterson scoring system was seen pre-operatively and at regular intervals post-operatively also, with p-value of 0.01. And dorsiflexion and plantar flexion was also assessed. This is the statistical analysis of the VY plasty surgery, and all these things were again assessed at regular.
5 minutes, please conclude quickly.
Yes, sir. And there was one complication also in the VY plasty, and with the gastrocnemius soleus fascia turn down graft, we found 2 patients out of the 7 for which had wound adhesions and some infection. And then again, the p-value for this was less than 0.001. So in conclusion, the functional improvement in the VY plasty and gastrocnemius soleus turn down flap was far better than the Krakow surgery. And also for the gastrocnemius turn down graft, the return in plantar flexion was the best amongst these 3 surgeries. And I think that a strategy can be formulated based on the rupture length of the Achilles tendon, which can avoid using nearby tendons also and yield satisfactory results by using just the Achilles tendon and the surrounding gastrocnemius fascia. And a larger prospective study is required to design the strategy for chronic Achilles tendon rupture. Thank you, sir.
Questions from panelists, please.
Well, Dr. Anand, it was a good presentation. A couple of things I want to know.
Yes,
With chronic rupture, you means it is a neglected rupture. Is that right?
Yes, sir. Rupture in which patients presented after 6 weeks.
So they're neglected.
Yes, sir.
Right. Not there was a chronic condition, something which led to slow
No, sir.
wearing of the tendon. Right.
No, sir, neglected.
So the main problem in such surgeries we always find is the local wound healing problems.
Yes, sir.
And you did mention in gastrocnemic flap cases that you had 2 cases, but in others you did not have any problem in wound healing in all other cases?
Sir, amongst these 22 patients, we found there were 3 patients which had wound adhesions and wound healing problems, but otherwise, in the post-operative period, we used to put them in a prone position for the first 12 days with the above knee slab, and then we used to do night splinting also. So with that, there was very less wound adhesions.
Okay. And I think, as you very rightly said, we need a much larger study to reach to a conclusion which approach would be better for which patient. I mean, 21 patients, I think, is too small to make a firm statement on this.
Yes, sir.
Dr. Anand, any experience on adding a reinforcement to your completion of the procedure? Say something like a tendon graft.
So for this study, we did not add any other reinforcements. We were more into we wanted actually to just use the tendo Achilles, the original anatomical tendo Achilles, and the gastrocnemius fascia to reconstruct the ruptured part. But apart from this study, we have used we have used tendon other tendons also, sir, and other things like that. But for this particular study, we did not use anything else.
And I believe this study was excluding the avulsions. Was it including the avulsion injuries, where the TA just goes off from bone? Or
No, sir. No, sir. It was excluding avulsions. This was no patients were of bony injuries.
Okay.
Thank you, Dr. Anand. So the next presenter is Dr. Kritesh Mishra. I think he'll be presenting on to study the functional outcome of elderly patients having intertrochanteric femur fracture treated with hemiarthroplasty. Dr. Kritesh, please share your screen. Over to you.
Sir, are you able to see my screen?
No, Kritesh, share it again. Have you shared? Kritesh, first open your PPT. Have you opened it?
Are you able to see my screen, sir?
Yeah, your screen is visible, but your PPT is not. Yeah, now it's coming.
Turn the slideshow on. Yeah, go ahead. Your time starts now.
Good evening, everyone. My title is to study the functional outcome of elderly patients having intertrochanteric femur fracture treated with hemiarthroplasty. So, intertrochanteric fracture in the elderly patient is a frequent problem and is becoming more common as the proportion of elderly people in the population increases. Unstable IT femur in elderly patient is associated with high rate of mortality, as much as 20% during the first post-operative year. The treatment of such IT femur fracture is still controversial, particularly the osteoporotic and unstable ones. So the aim of our study was to assess the functional outcomes of intertrochanteric femur fractures treated with primary hemiarthroplasty using Harris hip score, and to study the advantages and complications associated with hemiarthroplasty. So coming on to material and methods. Study design, it was a prospective observational study The study duration was of 18 months from July 2018 to December 2019. The study was conducted in our tertiary care hospital, Department of Orthopaedics. Total sample size was of 25 patients, and study population was of IT femur fractures, which fell into our inclusion criteria, aged greater than 65 years old. So our inclusion criteria was AO type A2, that is multifragmentary types of skeletally mature patients and age greater than 65 years. Exclusion criteria was AO A1 and A3, and fracture neck of femur, age less than 65 years of age, or any other associated fractures like shaft fracture or acetabulum fracture. We also excluded compound injuries and reverse oblique patterns. Also, the pathological fracture was not included in our study. Thorough history and examination was done. Radiographs, proper radiographs were taken, and pre-fracture ambulatory status was assessed using Harris Hip score. The modified Harris Hip score were recorded for the patient at discharge, at 1 month post-operative period, and at 3 months. These scores were to be used as an outcome measure of functional recovery in activities of daily living. So visual analog score and Harris Hip score was used as an outcome measure. Now coming on to the observations and results. Demographic profile. Most of the patients were between the age of 76 to 85 years of age. And most common mode of injury was fall, followed by RTA. Around 80% of patients were female and 20% were male. The patients presented from duration of trauma to treatment was greater than 7 days in 17 patients. There were few complications. 3 patients had superficial infection, 1 had deep wound infection, and 2 patients had bed sore. Outcome measure using VAS score. VAS score significantly improved from discharge to post-op 1 month to post-op 3 months. Harris Hip score. Harris Hip score also improved from discharge to post-op 1 month to post-op 3 months. The mean VAS score at discharge was 5.15, which improved to 3.52, and post-op 3 months. The difference in VAS score during follow-up period was statistically significant as per the ANOVA test. The functional daily activities in patients were measured by Harris Hip score. The mean Harris Hip score at discharge was 65.88, which improved significantly at post-op 1 month and post-op 3 months. The difference was significantly, statistically significant as per the ANOVA test. These are few examples of our cases. Now to conclude, cemented bipolar hemiarthroplasty offers a modality of treatment that provides adequate fixation and early mobilization in patients, thus preventing post-operative complications. This will have a direct effect on the general condition and post-operative rehabilitation. Good clinical and functional outcomes assessed as per our Harris Hip score were obtained, showing fair to excellent results. The mean Harris Hip score at discharge improved significantly at post-op 1 month and post-op 3 months. Thus, bipolar hemiarthroplasty can be considered as one of the modalities for primary treatment of IT femur fractures, particularly in patients greater than 65 years of age with osteoporotic bone. That will be all. Thank you.
Thank you for sticking to time. Questions?
Dr. Kitesh, well, very good that you finished in time. Interesting study, but it raises many questions. I mean, we all know that there are many modalities to treat intertrochanteric fractures, and you have taken one particular way and that just assess that. So we have no comparisons. I mean, there's no comparison that we have a nailing or a DHS. How much would have been had it been a comparative study that would have been more, giving a more message. One. Number two, this hemiarthroplasty in such cases is not an easy job. I mean, I'm sure you must have seen that as compared to simple arthroplasty in a case where you have a neck femur or something, is quantum of surgery is more. And implants, mostly you need special implants, longer stems and with shoulders and other things, calcar replacing stems we need. So leads to much more morbidity on the patient. We all know that after hip surgeries in this elderly group, the mortality is very high, up to 50% in some of the studies in 1 year. So it's not, I mean, it's too much to say just simply that we have done this study, so this can be one viable solution. You have to do a comparative study, and then only you can draw a conclusion. And secondly, you need a follow-up. I mean, more than a year or 2 year follow-up in such cases. How fairly have they done? I mean, then only you can give a statement of that kind.
Absolutely right, sir. A comparative study will be a better option here, considering hemiarthroplasty with osteosynthesis.
Yeah, that's right.
Sir Kataria, sir, any question?
I was wondering, Dr. Kritesh, you opted for hemiarthroplasty instead of a total hip arthroplasty, which is actually if at all one needs to do in an unstable fracture, why not a THR? Why a hemi? Any particular reason? Is it something which is there in textbooks?
Nothing like that, sir. If I agree with you, if the patient has a better ambulatory status, THR is a better option. But our study focused
at a very young stage. You pick them up at barely 65 and you've given them hemi, which is likely to fail in the next 5 to 7 years. So why not, and going for as Dr. Sharad pointed out, a fairly morbid surgery, pick it up and do a fair job instead of doing a hemi. Just a suggestion.
Right, sir. I agree to you.
Thank you, Dr. Kritesh. The next speaker is Dr. Srijit Srikantan. He'll be the next speaker is Dr. Ashish Ragashe from Tumor to Trauma. He'll be speaking on evaluation of outcome after resection and ankle arthrodesis for malignant and aggressive tumors of the distal tibia. Dr. Ragashe.
Thank you, sir. My screen is visible to all?
Yes, please start the slideshow.
Okay. I am Dr. Ashish Kumar Agase. I am a fellow of musculoskeletal oncology at AIIMS New Delhi. Today, I'll be speaking about the evaluation of outcome after resection and ankle arthrodesis for malignant and aggressive tumors around, of the distal tibia. Tumors around distal tibia are relatively rare as compared to other sites of the body, and 70 to 95% the distal tibia tumor patient can undergo reconstructive surgeries. Limb salvage versus amputation have a fair amount of acceptable functional outcome and survival. However, the appropriate method of reconstruction is still controversial. There are various techniques in the literature, for example, massive allograft, autograft, or a recycled tumor-bearing bone, or vascularized or non-vascularized fibula, prosthetic replacement, bone transport, nail cement spacer. However, the best suitable method of reconstruction is still controversial. Functional outcome in most of these studies have shown to be around 20 to 100% when we see with the musculoskeletal tumors society score. And there is a high rate of complication as well, such as non-union, fracture of the graft, or deep infection, which ranges around 4 to 92%. What are the challenges in this distal tibia? First is a poor soft tissue envelope, which therefore the reconstructive surgeries like processes, there is a high rate of infection or aseptic loosening and failure. And in biological method, again, there is a chances of non-union, graft fracture and infection. And since it's a very rare site of involvement, the no superior or better method of reconstruction has been established in any of the studies so far. We are presenting a study which was a retrospective study, which was done in from January 2017 to January 2020 in the patients which have malignant and aggressive benign tumors of the distal tibia. We did limb salvage as well as amputation in some of the patients. Method of limb salvage was either biological or non-biological, and we looked on for the implant survival and the functional outcome. We also looked for the complication and overall patient survival. The inclusion criteria were patients with a histologically confirmed primary tumor of the distal tibia. All patients were evaluated using X-rays, MRI, and histopathological examination was done. HRCT and PET scan were done in malignant cases. Neoadjuvant chemotherapy was given as per the protocol in the patients of osteosarcoma and Ewing sarcoma. For osteosarcoma, it was doxorubicin, cisplatin, and Ewing sarcoma, they have given dose-dense regimen, vincristine, doxorubicin, cisplatin, which was alternated with etoposide in 2 to 3 weeks. These are the demographic of patient. There were 5 male, 2 female. 4 lesions were on the left side, 3 were on the right side. Average age was 22, ranging from 12 to 45. There were 4 cases of osteosarcoma, 1 case of Ewing sarcoma, 1 of GCT, and 1 of adamantinoma. The surgical procedure involved either biological resection, in which we have used the treated tumor bone like ECRT, where intercalary resection was done and joint were preserved. We also have done orthodesis using autograft or allograft. Non-biological reconstruction, we haven't done any processes as such. We have used nail and bone cement displacer, and in 1 or 2 cases, amputation was done. There were 4 cases of biological resection. In 1, ECRT was done, and in 3, orthodesis was done. In 2 cases, we have done nail cement displacer, and in 1 case, from the primary surgery was below knee amputation. For example, this is a case of 12-year-old female with Ewing sarcoma of distal tibia. Here, the joint was not involved. So here we decided on to go for the intercalary dissection. These are the MRI. Here we have resected a tumor. The tumor was sent for the radiotherapy, and it was re-implanted with the use of distal tibial locking plate, and added 1 more plate was added at the proximal side to promote union. We also added the fibula, contralateral fibula for the union. This is the follow-up pictures at 18 months. The patient has a good functional score. She was able to sit, squat, and there was a limited, the dorsiflexion was quite limited. This is again a case of 14-year-old male with osteosarcoma. Here the joint was involved. So here we planned for going for an orthodosis. Here, after tumor resection, we have used allograft and the ipsilateral fibula for this for the orthodosis. This is 3-year follow-up. The patient has a good functional outcome. This is the video of the patient walking. And there is another patient where again the joint, we cannot preserve the joint, so we decided for the using nail cement displacer. After the tumor resection,
5 minutes.
The gap was filled with the bone cement and established using a nail and a plate. This is the result. The mean follow-up period was 28 months. 2 out of the 7 patients died due to the disease. 1 patient initially treated by nail cement displacer had to undergo below knee amputation. 4 patients were left out for functional outcome. MSTS score in 1 patient with Ewing sarcoma, in which ECRT was done, was around 28. 3 patients with bone orthodesis has MSTS score of 20, 24, and 27, 30 each. We believe that the limb salvage is safe and elective in the management of a malignant or aggressive lesion of distal tumor. Reconstruction with treated tumor bone, autograft orthodesis, and nail cement displacer orthodesis can achieve durable and satisfactory functional results. Thank you.
Thank you. So, any questions?
Dr. Shri, again, a very interesting study. Only thing is that your sample size is too small. And you say out of 7, 3 had died already.
Yes, sir.
So you could conclude only with 4 of them. And another again question comes about the complication in such situations. As you said, that healing is not easy in these areas.
Yes,
and
sir.
doing ECRT and even doing orthodesis. How much was the complication and wound healing problems you had in such cases?
So as the sample size was very small, only the 4 patients were left. The one in which we have done ECRT, there was no issue of any wound healing and all. The 2 patients as such, I have shown the result. The wound was, I mean, there wasn't any issue from the starting as well. But with one the patient which had a recurrence, he has some sort of, the cement was exposed initially, and when he came as to for the follow-up in the PET scan, it shows a sort of recurrence also. So one patient had a wound healing problem, but the rest 4, as such, they are doing well.
Okay.
Kataria sir, any question?
I think very good presentation, Dr. Ashish.
Thank you, sir.
I think you probably would. I mean, the kind of surgical procedures are fairly diverse, which you have, revealed in your presentation. I wish we had some longer
Yes.
follow-up. That will be really good, and
Yes, sir.
maybe we can come to some conclusion as to what particular procedures to take with what kind of that message. I think I will be happy if I can
I mean,
have.
sir, this is as such a very rare site of tumor
Exactly.
involvement. Yeah, and most of the surgeons prefer for a below knee amputation. Even the patient might prefer for below knee amputation rather than going for a long surgeries and with the wound complication and all. So it's as such with the 9 patients or even less than that, it's very difficult to say which method of reconstruction will be better. But yeah, still we have tried for ECRT thing and some orthodoxies. I think that can be attempted and that choice can be given to the patient.
Exactly. I think you should continue. It's a very good work. You should continue and come out with some, conclusive. You are sitting in a tertiary place with all ancillary facilities. I think that's the best place to go about this kind of stuff.
I think I agree. Long follow-up and longer, bigger sample. That would be able to conclude something.
Exactly.
Thank you, Dr. Akase. The next speaker is Dr. Srikantan. He'll be talking on osteonecrosis of femoral head. Is regeneration with PRP and growth bone grafting a real possibility in its management? Dr. Srijit.
Thank you, sir.
Please, slideshow.
Visible, sir?
Yeah, go ahead.
Okay, sir. Sir, my title of my presentation is Osteonecrosis of the Femoral Head. Is regeneration with PRP and bone grafting a real possibility in its management? Osteonecrosis is a painful condition that occurs when the blood supply of the head of femur is interrupted. In the various studies for the treatment of osteonecrosis of the femoral head by co-decompression with or without bone grafting showed fair to good results. There is lack of literature to assess whether adding platelet-rich plasma to this procedure will improve the results or not. Therefore, we conducted a study to find out the effect of co-decompression with autologous cancerous bone grafting and PRP for healing in osteonecrosis of the femoral head. The medical health methods, 20 patients with a stage 1 and 2, stage 1 and 2 AP of wicked are related classification of AV and of hip in the age group of 20 to 60 years are selected for a study. A detailed history of and a clinical examination were done. The preoperative Harris score was calculated for each patient, and the patients were evaluated with X-rays and MRI. There were 10 patients with stage 2A, 7 patients with stage 2B, and 3 patients with stage 1 disease preoperatively. This is the Fickett and Arlott classification of osteonecrosis of the femoral head. Stage 1, it will be a normal radiograph only. Stage 0, it is a normal radiograph only. In stage 1, there will be minor osteopenic changes. In stage 2A, there will be sclerosis or cystic lesions. Stage 2B, there will be a crescentic sign. In stage 3, there will be flattening of the femoral head or the femoral head collapse, but the joint space will be normal. And the stage 4, the joint space will be decreased and there will be osteoarthritic changes in the acetabulum also. So coming to the surgical technique, on the day of surgery, 25 ml of blood was taken from the patient 30 minutes before the surgery to prepare the PRP. The patient was taken supine on a fracture table. The quadrants of necrosis were predetermined from MRI. Standard co-decompression was done with 8 mm coring reamer direct in that quadrant. All the dead materials were curated out with small curettes. The table was tilted towards the opposite side. And the space was filled with the cancellous bone graft which was taken from the iliac crest. The platelet-rich plasma was infused into it through a long needle. The whole of the core decompression tract was closed with a cortical piece of bone from iliac crest. The wound was closed in layers, and the patient was kept inclined towards the opposite side for the night by keeping a pillow under the operator. These are the intraoperative photos. We put a small incision around 5 centimeter, and then we put a guide wire directing to that quadrant. This is the intraoperative CM photos. Here we have put the guide wire. Over the guide wire, we have done reaming. Then with an implant, we have removed all the necrotic tissue. On my right hand, this is the necrotic material, and on my left hand, this is the iliac crest graft. And with the bone punch, we have inserted the graft into that necrotic quadrant. This is the PRP we made. PRP was filled in a syringe and it was infused into the tract. And coming to the post-op care, the skin traction with Thomas Splint was done for the first 72 hours, and injectable medications for 3 days and oral antibiotics till suture removal. After 48 hours, dressings was changed, and we have advised non-weight bearing for 3 weeks, partial weight bearing after 3 weeks, and full weight bearing after 6 weeks. And the patients were followed at 1.5 months, 3 months, and 6 months. The functional outcomes of the procedure were assessed by Harris score and was compared with the preoperative Harris score. The radiological outcome of the procedures was assessed by MRI at 6 months and was compared with the preoperative MRI findings. At the end of 6 months, there were 8 patients who showed the remission of the disease. 10 patients showed limitation to the preoperative stage, and 2 patients progressed to the further stage. The mean standard deviation of preoperative Harris score was 55.6 plus or minus 11.06, and the postoperative mean plus Harris plus standard deviation of Harris score was 82.6 plus or minus 8. There were 4 patients with excellent HSS, 9 patients with good, 5 patients with fair, and 2 patients with poor HSS at 6 months follow-up. On applying paired t-test, the p-value for the pre and post-operative HSS was less than 0.0001. So there is a grading of this is the grading of this Harris score. If the score is in between 90 to 99, it is excellent. 80 to 89, it is good. 70 to 79, it is fair. And less than 70, it is poor. So preoperatively, we had 14 patients. Preoperatively, we have 14 patients with a poor HSS and 6 patients with a fair HSS. And postoperatively, after 6 months, we got only 2 patients with poor HSS, 5 patients with fair, 9 patients with good, and 4 patients with excellent HSS. The same thing I have shown in the graph. So we concluded that adding PRP to the core decompression with bone grafting gives improved results at short-term follow-up in the pre-collapse stages of osteonecrosis of the femoral head, but long-term follow-up is awaited. This is the preoperative MRI showing the lesion. This is the post-op MRI at 6 months. Previously, this patient was not able to squat and sitting cross-legged, but now he's able to do. And you can see the scar of surgery also. Thank you, sir.
Question, sir?
Dr. Shreejit, what I understand is that what you did was that in a standard method of core decompression with the bone grafting, you just introduced some PRP as well.
Yes, sir.
So it's very difficult to say whether the results you got were they because of core decompression plus bone grafting, or were there any advantage of having PRP also there? Again comes the question of comparative study. If you had done certain cases without PRP, some with PRP, then you could have concluded better. And so in this kind of a study, it's very difficult to say that PRP has any role at all or not. Am I right?
Actually, in the previous studies, they were telling that the results were getting, what we are getting is fair to good only. But in our results, we have got 2 patients with excellent Harris score, sir.
No, I'm saying we have not introduced PRP. Still, we may have got similar results with the core decompression plus bone grafting, which is a standard procedure in any case.
Yes,
Isn't it?
Yes, sir.
Right. Dr. Kataria, please.
Yeah, so Dr. Srijit, I think osteonecrosis is quite an enigma in terms of management. I just want to ask you, when you put the bone plugs, then you put the PRP, you tilt the table. Is there any way to try to make sure the PRP doesn't flow out?
Sir, your voice is breaking, sir. Hello?
Yeah, I just want to know that is there any way that you make a provision that the PRP doesn't flow out? Just a tilt of the table is enough?
That we have done, sir.
No, I mean, do you the cannulation that you do you provide a bone plug to make sure that the PRP doesn't flow out?
Yeah. From a cortical bone, we have placed it where we have closed the track, sir.
So you close the track by, okay.
Yeah.
I guess your follow-up is too short, but
Yeah, only 6 months follow-up we are done.
Very short follow-up. So I think we'll have to work on that. And what Dr. Sharad is saying, we really don't know what is working in this situation. So I think it's probably, if Dr. Sharad agrees to it, I think it's worth a go for these kind of situations. It's a complete enigma, sir. We all know that.
That's why we, in the conclusion, we said that the long-term follow-up is needed, sir.
Okay. And does the PRP that you put, does it contain an anticoagulant? Do you add an anticoagulant into the PRP?
Sir, actually, we have collected the blood in EDTA vials, sir. Then only we have sent it to the blood bank, and from that centrifugation was done. Then only we made prepared PRP.
Okay.
So in that EDTA vial, there will be anticoagulant.
Right.
Thank you, Dr. Srijit. Next speaker is Dr. Palash Gupta. He'll be talking on role of multiplanar ligamentautaxis in the management of distal radius fractures using a modified external fixator spanning the wrist. Dr. Palash?
Sir, I'll share my screen, sir.
Yes.
Good evening, everyone. Myself, Dr. Palash. I'll speak on a topic, the role of multiplanar ligamentautaxis in the management of distal wrist fractures using a modified external fixator spanning the wrist. External fixation is a well-accepted modality of treatment for distal disc fracture, especially the unstable ones. They employ principles of ligamentautaxis for fracture reduction and maintenance. However, most of the conventional fixators use uniplanar ligamentautaxis, which reaches to the normal volar tilt. Gupta in 1991 showed better results in terms of restoration of volar tilt and hand function by immobilizing the wrist and dorsiflexion. Agee in 93 utilized multiplanar ligamentaxis to overcome this inability to restore the normal volar tilt. He evolved external fixator with integrated double ball joint, where volar translation of proximal carpal row caused tightening of the dorsal capsule, where wrist dorsiflexion causes tightening of volar carpal ligaments, both producing ligamentaxis. Even Stryker in its external fixator utilized this model and called it as Gupta's maneuver. However, due to thin and poor quality of dorsal capsule of the wrist, a poor ligamentaxis is produced. We evolved a method to give direct push to the distal radial fragment via dorsal pin, along with ligamentaxis from volar ligaments via dorsiflexion of wrist. The present study was aimed to assess the efficacy of modified multiplanar external fixator in treating distal radial fractures in terms of restoration of normal anatomy and hand function. The study was conducted in the Department of Orthopaedics, Lok Nayak Hospital. It was an interventional study for a duration of 1 year with sample size of 10 patients. Patients with age 18 to 60 years with extra-articular fractures with displacement and metaphyseal combination with duration of injury of less than 2 weeks were included in the study, while patient with intra-articular extension, volarly displaced distal disc fracture, and patient having injuries of the same limb were excluded. My primary outcome measures were the radial tilt, radial inclination, radial height, and the ulnar variance. The secondary ones were the grip strength, range of motion, pain, this is using the VAS score, and Mayo score. Data analysis was done with the help of statistician, and a p-value of less than 0.05 was considered significant. For surgical techniques, initially a conventional fixator was placed, then the dorsal pin was placed in the distal fragment using the C-arm, and then the maneuvering of the distal fragment using this pin was done and entered into the assembly. Then the distal clamp was loosened and the wrist was now dorsiflexed. Final reaction was checked in the C-arm and was acceptable, as shown in this diagram. Results, the radial tilt was improved from a 19 degree of dorsal tilt to a 11 degree of volar tilt, achieving about 84% of the normal side. Radial height was achieved about 65% of the normal side. Radial inclination achieved about 95% of the normal side. Grip strength was achieved about 48% of the normal side. Mayo score at 6 months, we achieved 65.50, and range of motion in all domains were compared from the normal side, ranging from 25 to 95%. Here in this chart, we can see the grip strength was seen to improve throughout the follow-up, maximum in the 24 weeks. Volar tilt was improved after the intervention and remained static throughout the follow-up. Radial height improved after the intervention, and a minimal loss in height was seen. Mayo score continued to improve throughout the follow-up. Pain score significantly improved with the patients having minimal pain at the final follow-up. All our cases were extra-articular fracture of distal layers with combination more than 1/3 of the epidiameter and more than 10 degree of dorsal tilt with 3 mm of shortening. Most of these fractures occurred in the elderly females with mean age 53.6 years. These statistics were comparable works of Atkin et al., Werber et al., and Sadigan et al., and Theodor et al., who worked on their conventional fixators. 7 out of 10 patients were absolutely pain-free, whereas others had pain score of 1 at the final follow-up 6 months. Real height was acceptable in 7 out of 10 patients. Previous studies achieved 65 to 75% of the normal side, the height. Loss of height can be explained due to the poor flow of dorsal pin, extensive metaphyseal combination, and stress relaxation of the ligaments. Radial tilt was corrected to a mean of 11.2 degrees, reaching about 85% of the normal side. The previous studies reported a correction about 2 to 8 degrees in their conventional fixator groups. Radial inclination was satisfactory in all patients, and results were comparable to the conventional fixators. Grip strength was achieved about 48% of the normal side. Previous studies reported about 44% of the normal side, and grip strength is likely to improve with further follow-up, unlike radiological parameters which achieved a normal plateau. Range of motion were lied well within the all domains within functional limits, and results were comparable with existing literature and were expected to improve further in the follow-up. Mean Mayo score was 65.5, and the ratio of good, fair, and poor was 3:3:4. Mayo score is also expected to improve with further follow-up. Pin tract infection was seen in 2 of our cases with CRPS in 1 of our cases. The results were comparable to the works of Atkin et al., who reported 3 cases of pin site infection, CRPS in 3, and radial nerve injury in 1 of our cases out of all 22 cases. Here is one case of one of our patients with the pre-op, immediate, and 24 weeks X-ray.
30 seconds to go.
All our case achieving acceptable reduction in volar tilt. The proposed for take-home message, the proposed fixator offers promising result in terms of restoring normal anatomy and good hand and dysfunction. However, a larger duration of follow-up is required to establish a true functional outcome. It has been shown to be very effective in terms of restoring normal volar tilt, which otherwise is seen to be the most difficult parameter to be restored with other current fixators. That's all. Thank you, sir.
Dr. Palash, what I could gather from your procedure is that in a conventional external fixator, you are passing another pin which is going anteroposteriorly to control the tilt, radial tilt. Is that right?
Yes,
rest
sir.
of the system is same.
Yes, the rest of the system is same. We also immobilize the wrist in dorsiflexion, sir.
Okay, with the help of that extra pin.
The pin won't help in, sir, dorsiflexion wrist, but we'll
okay, this only. Okay. So that's the additional you are doing. Now the question is that did say that you are using it in a comminuted fracture. What our experience is that extra articular fractures are, number one, are not that much of a problem. I mean, they're not difficult to control. Yes, and the examples which you shown, I think those example can be very easily controlled by simple passing 1 or 2 pins subcutaneously and giving a cast. I mean, where is the need of putting extra armamentarium like 2-3 pins and other things? I mean, it's very easy to control these by simple passing a pin percutaneously after doing reduction. And secondly, unless you have a comparative study with a normal conventional external fixator, then only you can claim some extra advantage with your kind of a fixator. This is my comment.
Yes, yes, sir. Sir, the basis for conducting, sir, was our already established results from the previous studies, and through this we could see, sir, the polar tilt was the most difficult parameter which was able to restore. So, through the help of this pin and through dorsiflexing the wrist, we were able to achieve, and we hypothesized achieving it a normal volar tilt through both these things, which were difficult to restore with use of conventional fixators, especially the volar tilt.
Right. Okay.
Dr. Rajesh, can I ask something?
Yeah, please carry on.
Yes, sir.
Yeah, Hitesh, carry on.
How many patients did this pin hold in the distal fragment? It might be very osteoporotic. And secondly, you inserted only one pin, and that should be stable in only one dimension. And the fragment would be able to rotate in the other plane. So how effective was it? Only a single pin was effective.
Sir, our motive through this pin was to give a volar torque with the help of this pin, pushing it volarly, giving a volar torque. And we have seen in 2 cases the pin got loosened and producing adverse effects in that case, while rest of the cases the pin seemed to have a good hold and with a acceptable volar tilt.
Did any patient develop Sudex dystrophy?
So one of our patients developed Sudex dystrophy, sir.
What was the cause in that?
Sir, we believe excessive traction while reduction of a fragment could be a possible cause for the development.
Okay. Dr. Himanshu, please.
Dr. Palash, you retain the dorsal pin till the complete removal of the fixator, or do you remove it in between?
Sir, we remove the pin once the radiological confirmation of healing is bone union is confirmed and with the fixator.
So you remove the pin and the fixator en masse at the end of it, or
yes.
Do you remove the dorsal pin first at some stage, I say at about 3 weeks or 4 weeks?
Sir, en masse.
You remove it en masse. Okay.
Yes.
And do you have any experience of combining it, using it as a hybrid kind of a fixator, using it with some internal fixation?
Sir, there have been study. No, sir, I don't have experience.
Had that experience, sir?
Sir,
That's
pin
okay.
Used to.
Your study was probably not. So I wish that you can add up some comparative thing. Then
yes, sir.
You have evaluated the functional outcome. I think the way to go forward is to probably add a comparative evaluation.
Yes, sir.
Thank you.
Thank you, Dr. Palash. Next speaker is Dr. Anmol Sharma. He'll be talking on a prospective study of the functional outcome in fracture neck of femur treated by cemented bipolar hemiarthroplasty in elderly patients. Dr. Anmol.
Yes. Good evening, everyone. Myself, Dr. Anmol Sharma, presenting the study on prospective study of the functional outcome in fracture neck femur treated by cemented bipolar hemiarthroplasty in the elderly patients. Now, femoral neck fracture, they comprise the majority of the hip fracture in the elderly population and most commonly in the elderly females. And the burden of these fractures on the annual cost and the healthcare system is on rise. Now, there is a widespread variation in the treatment of these fractures, which include the reduction and fixation, unipolar hemiarthroplasty, bipolar hemiarthroplasty, and THR. Now, internal fixation has proven higher reoperation rate as compared to hemiarthroplasty in elderly patients in study. And the advantages of bipolar prosthesis over the unipolar one have been proven in terms of satisfactory results, post-operative pain, range of movements, and return to the unassisted activity. Now, the aim was to study the functional outcome of the fracture neck femur using the Harris-Hip score. We evaluated the pre-operative, intraoperative, and the post-operative factors and their effect on the final outcome. And we assessed the improvement in daily life activities and complications following the surgery. Now, patients with fracture of the femoral neck, age 60 years or more with failed internal fixation or with avascular necrosis secondary to fracture of the femoral neck. In our college, they were included in the study, and patients who were excluded were below 60 years of age with arthritic changes in the acetabulum as a fracture associated with malignancy and patient not willing for surgery or medically unfit. Study center was Allen Medical College Research JK Hospital Bhopal from January 2019 to 2020. It is a prospective observational study. We evaluated the patient pre-operatively with clinical and social history, clinical examination, comorbidity evaluation, and pre-anesthetic evaluation. In intraoperative, we noted the duration of surgery, blood loss, prosthesis size, and the intraoperative complications. And post-operatively, we evaluated clinically, we evaluated the post-operative complications and rehabilitation. Follow-up was done clinically and radiologically, and functional assessment was done using the Harris-Ip score. These are the results. 85% patient, they fall in the age group of 60 to 69. Mean age was 64.3 plus minus 7.66. 78% patients were female. 58% patient had right side fracture. And in 87% cases, we had low energy trauma. 55% has an anatomical type, transcervical type. 33% has subcapital and 20% had basi cervical. In gardens, we had no patient with type 1. 57% had type 4. 40% had type 3. In Powell's, we had no type 1, 97% had type 3 and 3% had type 2. 90% of the patients, they were in the Singh index grade 3 or below. Most of the patient had hypertension as comorbidity, and the duration, the interval between the trauma and the surgery mean was 11.05 plus minus 7.46 days. Duration of surgery mean was 95.33 plus minus 13.71 minute. Most common size which was used as prosthesis was 45 mm followed by 43 and 41. Blood loss in most of the patient was less than 200 ml. And this is the duration of hospital stay. Most of the patients were discharged between 15 to 21 days. In intraoperative complications, 2 patients had hypotension, 1 patient had blood transfusion reaction. In early postoperative complications, 4 patients had superficial infection, 2 patients had limb lengthening. Now, follow-up was done at 2 weeks, 4 weeks, 6 weeks, up to 12 months. At the end of 12 months, out of 60 patients, we had 42 patients for final follow-up. Mean Harris-Ip score was 85.83 plus minus 7.43. 18 patients, 43% patient had excellent results, 16 patients had good results, 5 patients had fair results, and 3 patients had poor result. These are the pre-op and post-op images, and the images of the patient in various movements of the hip joint. Now, in our study, 42 out of the 60 patients, they were available for final follow-up. 80.95% patient, they had excellent to good results. 11.90 had fair, and 7.14, they had poor results. Now, the effect of age, sex, site of the fracture, type of fracture, comorbidity, duration of surgery, interval between trauma and surgery on the final outcome was insignificant in our study. Effect of duration of hospital stay and complications were found significant. No patient had late post-operative complication as the duration is of only 12 months of follow-up, like acetabular erosion, periprosthetic fracture, protuso-acetabular implant loosening, and maybe we require a more follow-up period to observe these complications, and none of our patients required revision surgery during the study period. In the end, I conclude with that the cemented bipolar hemiarthroplasty is a safe option for treating the fracture neck of the femur in elderly population, ensuring good and early rehabilitation in spite of comorbidities. It is a good option in developing countries, provide good ambulatory ability, improves the quality of life, and is cost effective. And here I conclude my presentation with this. Thank you.
Dr. Anmol, I think a very good presentation.
Yes.
The debate is always between hemiarthroplasties versus total hip replacement. I'm sure Dr. Himanshu will come back with that. And of course, in our hands, we have seen that hemiarthroplasty have done well, really fairly well. And in our long clinical experience, not many patients require a THR, soon. Only thing is that again you need a longer follow-up than 1 year to decide these things, and maybe a comparative thing, because THR is definitely have more likely to have more complications than peroperative and post-operative phases. I think otherwise hemiarthroplasty is a well-established procedure.
Yes. Yes, sir. Thank you. Yes, bipolar hemiarthroplasty has been proven good. THR has also been done, but at our center, they were mostly done in a higher age group or patients with having arthritic changes along with the fracture neck of the femur. So what I included is just cemented bipolar
Traumatic
hemiarthroplasty.
cases, yes, that's right.
Why did you not use cementless hemiarthroplasty?
Sir, in certain cases, we have used cementless where the fitting of the stem was good, but I have not done comparative study.
Okay. Was there any case of cement embolism or any rot?
Luckily, we don't have any bone cement implantation syndrome case.
Dr. Sharad, I remember there has been a white paper on fracture neck femur some time back from IOA, where very clear-cut operating protocols were described for neck femur, and hemiarthroplasty was way down. In fact, it's time actually that IOA and DOA actually evolve these standard operating protocols as is there in US, where I think all the younger generation, we know what exactly we are looking forward when we get to see some particular kind of a fracture. Rather than doing this, for example, there's no criticism of anybody, but a procedure like hemiarthroplasty, the average operating time 95 minutes. I don't know what the panelists feel about it, but I think we need to evolve a protocol.
I agree, Dr. Himanshu. My motto of this year had been weigh evidence and respect experience. So I know there's a lot of literature on this and a lot of evidence have been produced in favor of total hip replacement in such cases. But I said the clinical experience, mine, I don't know about you. You can also state your experience. Now we have fairly many years we have done your work. But not many hemiarthroplasties have come back with to us with needs revisions and they need any complications. I mean, that's true. I've not done any comparative studies. I won't be able to sort of emphasize on that point. But clinical experience goes that they do well with a small amount of surgery. I mean, less quantum of surgery, less likely of complications, early rehabilitation, I found good results.
Thank you, Dr. Sharma. Thank you, sir. I think the SOPs are still required for our country.
Absolutely.
Next speaker is Dr. Devendra Singh. He'll be talking on, is it worth doing proximal fibular osteotomy in middle compartment osteoarthritis of knee? A controversial topic, I think. Dr. Devendra, are you there?
Hello. Yes, sir.
Yeah, please share your screen. Any problem, Dr. Devendra?
Yes, sir. So just
okay. Dr. Akshay, are you ready with your presentation? Dr. Akshay Raj?
Dr. Devendra, what problem you are having?
Yes, sir. I couldn't. My presentation is ready.
Okay, Dr. Akshay, I think you can go ahead. Dr. Devendra can present after you. Dr. Devendra, you please sort out your issues.
Sure. Okay, sir.
Dr. Akshay Raj will be presenting on accuracy of extrinsic landmarks and intrinsic vertebral markers in level identification during anterior cervical spine surgery for traumatic subaxial cervical spine injury. Dr. Akshay, over to you.
Yes, sir. Sharing my screen now.
Start the slideshow.
Yes, sir. Are you able to see it, sir?
Start the slideshow.
Yes, sir. So, good evening, everybody. So, I'll be sharing my study where we've studied the accuracy of extrinsic neck landmarks and intrinsic vertebral markers in level identification in anterior cervical spine surgery for subaxial cervical spine injuries. So to get things rolling, the anterior cervical spine surgery is a very tried and tested methodology that's been used to treat subaxial cervical spine injuries. And classically, the landmarks that have been used to guide the incision placement have been the angle of mandible, your hyoid bone, the thyroid cartilage, and cricoid cartilage, which have been classically described in books such as Yeoman's Neurosurgery and Hoppenfield. However, real-world experience shows and studies have borne this out that age, sex, and body mass index particularly play a role in deciding which level that they correspond to, which means the classical teachings are usually not corresponding to what is usually seen in the real world. With that said, the literature also shows that intraoperative radiography is the most important factor in avoiding surgical treatment of the wrong spinal level. So coming to a country like India, which is still developing, many institutions still don't have access to radiographic imaging equipment that have been used for vertebral level identification. So the aim of this study was to evaluate the reliability of the extrinsic palpable anterior neck landmarks, which is used in level identification, and to evaluate the accuracy of intrinsic markers which are related to the level of injury in anterior cervical spine surgery. We included patients from 18 to 60 years of age of both sexes, and the subaxial spine was included as the C2, C1 and occipital cervical junction form a separate entity. And we also excluded patients with scivora and other non-traumatic conditions like tuberculosis, and patients with congenital deformities and other predating injuries. The method that we used was marker X-ray was taken with the patient positioned similar to the position that we used during surgery, with radiopaque markers placed, as you can see, placed at the angle of mandible, the hyoid bone, the cricoid, and thyroid cartilage. This was verified by 2 surgeons.
Dr. Akshay?
Yes, sir.
There is something problem with your sound actually. Is there anything that is sticking around you?
No, sir. I'm actually on my headphones.
Okay. Okay, go ahead.
Can I go ahead, sir? Yes, sir.
Yeah.
So this was verified by 2 surgeons after palpating the landmarks. Intraoperatively, the vertebral level were identified by palpating the injury-related morphological changes. These were categorized as bony lesions like teardrop fractures and vertebral body fractures, and a step off in case of a fracture dislocation, and soft tissue lesions due to the injury like annular injury of the disc, rupture of the anterolongitudinal ligament, and the disc osteophyte complex. So this level was identified, following which a confirmatory C-arm shot was taken before proceeding with surgery, and it was noted either as a positive level identification or, if correction was needed, as a negative level identification. So a standard anterior approach as described by Smith and Robinson was adopted, and either a discectomy or corpectomy was done as the case required, and a tricortical iliac crest bone grafting was done with fixation using the anterior cervical locking plate. So as this demonstrates the categories of markers that we used during our study. You can see teardrop fractures here, a step off between the C4 and C5 vertebral levels in the left lower corner of the screen. This shows the injury of the anterolongitudinal ligament and the annulus of the intervertebral disc being injured. The final picture shows a disc osteophyte complex. So this is just the operative steps. The standard anterior approach as described by Smith-Robinson, longus coli were retracted. The injured anterolongitudinal ligament noted on the preoperative MRI was identified, and then a marker was placed. A C-arm shot was taken to confirm the level before proceeding with further surgery, where discectomy, tricortical iliac crest grafting, and locking plate application were done. So coming to the results of our study, over an 18-month period, we operated 70 patients, and none of the patients, during none of the surgery did we encounter any injury to major vital structures like your esophagus, recurrent laryngeal nerve, and the carotid sheath. There was no dural injury iatrogenically produced during our surgeries, and postoperative X-rays showed that all the plates were acceptably placed with the graft placement and screw position being acceptable. And no patient in our study required any revision surgery. In our study, the mean duration was around 100 minutes for an ACDF and around 220 minutes for an and around 93 minutes for an ACCF for an ACDF and 100 minutes for an ACCF. The blood loss that was encountered was comparable to studies that had already been published in literature. So coming to the actual important results of our study, we found that the angle of mandible consistently corresponded to the C2 vertebral body in about 94% of our patients. The rest of the markers of the hyoid bone, thyroid cartilage, cricoid cartilage varied extensively as the graph demonstrates, where the hyoid bone classically being described to C3 was seen only in 49% of cases. About the thyroid cartilage corresponded only to in 45% patients to the C4, and the cricoid cartilage corresponded only in 47% patients to C5, C6 level, and only in about 28% of patients did it correspond to your C6. So coming to the bony markers, using the bony marker and marker X-ray method, we could correctly identify our operative levels in 82.86% of patients. And with respect to the type of marker, we could see that the soft tissue markers, namely the anterolongitudinal ligament injury, disc injuries, and disc osteophyte complex that were already seen in degenerative spines, when they were used, the error rate was around 43%. The rest of the cases, we could find only an error report of around. Yes, sir.
Please conclude.
Yes, sir. So our neurological recovery in incomplete injuries was 78%, which was similar to previous studies. And these are just illustrations. So the conclusion is that the technique detailed in this study, performed in a stepwise and consistent manner, is a reliable and safe method to operate on the subaxial cervical spine in ill-equipped centers.
Any questions from panel?
Dr. Akshay.
Yes, sir.
Are you trying to say that you're going to use these kind of techniques at places, at centers where you don't have a C-arm help during the surgery? Is that so?
Sir, the idea was to use like a portable X-ray machine where if you don't have a C-arm, because that was encountered.
Wrong level surgery is the biggest disaster we can have in a cervical spine injury.
Yes, sir.
Spine surgery.
Yes, sir.
Whatever method you yourself also showed that other than angle, mandible, other parameters were way
yes, sir.
off.
The mark. Yes, sir.
Way of
yes, sir. So I'm coming to that, sir. Yes, sir.
You have to have a per operative X-ray machine and X-ray.
Yes, sir. Literature shows that is the only foolproof method. But the thing was, when we found that when you perform a marker X-ray where the patient is positioned in the position that is similar to what you use in the OT, then you end up like giving the incision at more often than not at the correct level. So we basically eliminate the variables like position, the change of the markers with respect to the position of the neck of the patient. So you try to eliminate that factor and then you proceed with the surgery.
Because I understand we do definitely check at two levels. One is before giving the incision. And
yes,
second,
sir.
if we have reached the spine, then again
yes,
we
sir.
perform the level and then.
Yes, sir. Yes, sir. Yes, sir.
Right.
We took a shot only after we had opened up the case, sir. We gave the incision using our marker X-ray only.
So that is going to be the only ultimate confirmed level marker.
Yes, sir. But
other things, yeah.
The incision level, the study also shows that if you give incision at the wrong level, then you end up retracting a lot. There is higher chance of esophageal injury. So the level of incision also matters.
Absolutely.
Yes.
Even in pre-op,
yes, sir.
What you mark the levels, and
yes,
how do you ensure that the pre-op marker, the position of pre-op markers is the same as per-op position?
Sir, we took the pre-operative marker X-rays just on the morning of
the same
yes,
as
sir.
the pre-op marker.
Yes, sir. So we took the pre-operative marker X-rays on the morning of surgery, sir. And patient was shifted to the OT.
Cervical spine pre-op position while taking X-ray will be in less extension. Per-op you will be doing more extension.
No, sir. This X-ray was expressly taken in the position that was to be used in the OT, sir. So
And
like
this
two people,
technique does not
residents.
work in cases of discectomy only, where there are no any internal.
So sir, we've done corpectomies in
discectomy only,
patients.
only discectomy.
Only discectomy. No, sir, we need some intrinsic marker to proceed with the case. Just for a compressive myelopathy, just non-traumatic cases, this will be difficult. So for a traumatic case, this is feasible. Where injury-related changes give you a marker that can be identified intraoperatively. If this is a non-traumatic
Even
case,
in
this
old
is not
cases, more than
possible.
2 weeks, it won't work.
Yes, sir. Then it is difficult, sir. We had the facility of an OT, so we could proceed.
Okay, Dr. Akshay. Thank you.
Yes, thank you, sir.
Dr. Devendra, are you ready with your presentation? Dr. Devendra,
you were there now. Actually, Dr. Rajesh, he must be facing some problem, I think.
You can present in next session.
Devinder?
Sir, actually, I can't connect my slides.
Do one thing, dear. Just don't panic. You are on the Zoom. Just open the PPT on the desktop. Open your PPT first. Open your PPT.
I think he's using a tab.
Are you using tab?
Yes, sir.
Okay. Just you open the PPT. Is it an iPad or what?
It's an Android tab.
Android tab, no?
Sir, can I?
Have you opened?
Yes, sir. Just.
You are using camera of the tab now.
Yes, sir. I am opening on slide on.
Okay. What we can do go to the next presenter, Dr. Naveen, and then you can go ahead, Devinder. Please get it ready.
Okay.
The next presenter is Dr. Naveen Thaksha.
Dr. Naveen? He must be there. He came actually.
Yes, sir.
Naveen, share your PPT.
Okay, sir. One second.
He'll be talking on a study to assess the post-operative functional outcome in patients treated by cemented bipolar process for intracapsular neck fracture neck of femur.
Yes, sir.
Dr. Naveen, again, your background is noisy. Make it full screen and proceed. Make it full screen and proceed.
Sir, can I start?
Yes.
Yeah, Naveen, go ahead.
Good evening, all of you. Today I am going to present my poster on a study to assess the post-operative functional outcome in patients treated by cemented bipolar prosthesis for intracapsular fracture neck of femur. Introduction. Neck of femur fracture is one of the most common affiliation of the hip joint. Commonly seen in old people, prolonged immobilization due to fractures leads to increased morbidity and mortality. Early mobilization after hemiarthroplasty is necessary in intracapsular neck fractures. My slide, can you see my slide, sir?
Dr.
No, Naveen, it's not visible.
Dr. Devinder, please don't share your screen at present. Dr. Naveen, please start sharing again.
Naveen, share it again. Just unshare it and share it again. Dr. Devinder, please stop sharing your text.
Can you see it?
Yeah, please go ahead. Your screen is not visible. Yeah, go ahead. Naveen, go ahead.
Yes, sir. Displaced femur neck fracture is a genetic population and is associated with better functional outcome and fewer reoperative than internal fixation. Number of prostheses have been used with or without cement, and no definite conclusion have been made regarding which type of arthroplasty is preferred. Some evidence of inferior short-term results with decreased mobility and more pain when using an uncemented implant. Cement forms a solid bond between the prosthesis and the femoral bone. Bipolar prosthesis with cement is a good option wherein early weight bearing can be started. Aims and objective. To assess the postoperative functional outcome in patients treated by cemented bipolar prosthesis for intracapsular fracture neck of femur. My objectives: to evaluate the outcome in patients treated by cemented bipolar prosthesis for intracapsular fracture neck of femur by Harry-Hip score in terms of postoperative pain, limb, mobilization and distance walked, ability to perform daily activities, and range of movement at the hip joint. Methodology. This prospective study is conducted in the Department of Orthopaedic at SGT Medical College. Time period was between the June 2018 to September 2020 with the study population of 30 patients, over 30 patients. My inclusion criteria: intracapsular fracture neck of femur age 60 years and above were included in my study. Exclusion criteria: patient of age less than 60 years, associated osteonecrosis of head femur, pathological femur neck fractures, patients medically unfit for surgery. Results. Age distribution shows that there were more of the patients in my study. 19 patients were between the 60 to 69 year, and 10 patients between 70 to 79, and 1 patient was above 80 years of age. The average age was 66.5 years. On the basis of sex distribution, 16 patients were female and 14 patients were male. It suggests the females were more frequently sustained these type of injuries. On the basis of anatomical classification, five patients were basic cervical fracture, 14 were trans cervical fracture, and 11 were subcapital type of fracture femoral neck. Limb-length disparity, which was associated in 8 cases out of 30 cases. Shortening was seen in 6 cases, and lengthening of more than 1 centimeter was seen in 2 cases out of 30 cases. At Harry-Hip score at 6 weeks post-operative, the mean Harry-Hip score was 69.35, ranging from 51 to 77. 16 patients were rated fair, and 12 patients were rated poor according to Harry-Hip score at 6 weeks post-operatively. At 3 months post-operatively, the Harry-Hip score was 84.14, ranging from 62 to 91. Patients were rated 2 patients were rated excellent, and 21 patients were rated good, and 4 patients rated fair, and 1 patient rated poor according to Harry-Hip score at the 3 months. At the final follow-up of 6 months post-operative, the Harry-Hip score was 88.25, ranging from 66 to 93, and at this time 14 patients were rated excellent, and 12 patients were rated good, and 1 patient was rated fair, and 1 patient was rated poor according to highest score in the final follow-up. The mean value of Harry-Hip score at the patient at 6 weeks and then consecutive follow-up with their standard deviation and p-value. There is significant increase in Harry-Hip score till 6 months post-operatively. After that, there was no increase in the p-value was not significant at the 6 months interval. Post-operative complications. Out of 30 patients, post-operatively complications were seen in 3 patients. That is, superficial infection was seen in 1 patient, and deep infection in 2 patients. Dislocation was not there, and there was no casualty out of 30 patients. Discussion. The mean age of the cases with femoral neck fracture in my study was 66.5 years, and in the present study, the most common mode of injury was tribal trauma, and at 6 weeks post-operative, the mean Harry-Hip score was 69.35, and at 3 months in, the Harry-Hip score was 84.14, and at 6 months of surgery, the Harry-Hip score was 88.25. Conclusion. This suggested that cemented bipolar hemianoplasty is a good modality for management of fracture neck of femur with good to excellent functional results, minimum limb length disparity, and a low complication rate. A long-term follow-up of the patient is required for late complications in this procedure and long-term functional results. Thank you.
Thank you, Dr. Naveen. So, any questions?
I think same as we discussed earlier also is an established procedure. What we need is a long-term follow-up at our setups in our conditions to conclude how good is it in the long-term situation.
Yes, sir. It's the same, almost the same study. Dr. Devendra, are you ready with your presentation? Dr. Devendra?
Dr. Devendra, have you sorted out your issue?
Can I stop my screen sharing?
Yeah, you can stop your screen sharing. Thank you.
Thank you, sir.
Ravi, are we finished with this session or we are still left?
Sir, one presentation is left, sir.
Okay.
Dr. Devendra, sir. Then we'll move to second session.
Just a second.
Devendra, have you shifted on the laptop now?
Yes, sir.
Now open your PPT.
Dr. Devendra, probably you're using two devices, so your voice is echoing.
Switch off one device.
Sir,
Switch
how
off
can
your tab. Switch off your tab.
Yes, sir. I'm also.
Have you opened the PPT on desktop?
Yes, sir.
Now go to the Zoom. On the lower panel, there is a share button.
Share screen. There will be an option of share screen.
Green color. Got it?
Yes, sir. Just.
Then click on it. What happened?
So there are options like Dropbox, Microsoft on type.
I think we can proceed with the next session, and we can include this picture in next session.
So can you see this now?
Yeah. Now it's coming up. Start the slideshow.
Mode.
Start the slideshow and turn off your other device. The voice is still echoing.
Okay, sir. So, good evening, everyone. Myself, Dr. Devendra from Aramil Hospital. The topic of my presentation is it worth doing proximal fibular osteotomy in medial compartment knee osteoarthritis? As you all know, osteoarthritis of knee is a chronic, progressive, degenerative disease which can cause joint pain, stiffness, and deformity. It is a common joint disease with incidence of 30% in the population older than 60 years. There are multiple treatments for osteoarthritis like lifestyle modification, pharmacological management, and two main surgical modalities which can be used for treating osteoarthritis of knee is high tibial osteotomy and total knee arthroplasty. However, for younger active patient with moderate osteoarthritis, these may not be the treatment of choice. Knee load distribution. In healthy knees, the medial compartment bears 60 to 80% of the load, even with neutral axis, and the medial compartment shares large loads compared to the lateral compartment. Cause of medial compartment osteoarthritis are degenerative, partial or complete meniscectomy, femoral osteonecrosis, lower extremity trauma, ligament laxity, obesity, etc. Medial compartment osteoarthritis is associated with genu-varum, medial joint space narrowing, medial joint stiffness, and sclerosis of the subchondral bone. PFO is proximal fibular osteotomy is a simple surgical procedure which effectively relieves knee pain and also corrects varus deformity for patients with medial compartment knee osteoarthritis. It leads to shifting of mechanical axis from medial compartment towards the lateral compartment and improves mechanical alignment and function of the affected knee joint. It corrects alignment of the knee, relieving pressure from medial compartment of arthritic knee and transferring it to an area of more normal cartilage. Biomechanical basis of proximal fibular osteotomy. It causes unloading of the medial compartment. As we all know, in osteoarthritis, there will be more shifting of weight on medial compartment. After fibular osteotomy, there will be equal redistribution of load on knee. PFO is an emerging procedure, relieves knee pain and improves joint function by changing the mechanical axis postoperatively. The goal of PFO is to correct varus deformity and shifting of the mechanical axis from medial compartment towards the lateral compartment and significantly improves mechanical alignment and the function of the affected knee joint. Indication of proximal fibular osteotomy are patient with medial osteoarthritis knee, candidates who are suitable for high tibial osteotomy and unicompartmental knee arthroplasty, and varus deformity of the knee. Contraindication of proximal fibular osteotomy are valgus deformity of the knee, post-traumatic knee osteoarthritis, inflammatory joint disease, patient with previous fracture, patient having bone tumors. In all these patients, osteoarthritis usually involve all three quadrants. Materials and methods. Thus, the study is conducted in the Department of Orthopaedics in RML Hospital, and study design is prospective observational study, and the sample size is 20 patients. Study population. Inclusion criteria: patient age 45 to 65 years with medial compartment osteoarthritis knee, patient with American Knee Society score below 75, patient in which conservative management has failed. The exclusion criteria is patient with bi and tri compartment osteoarthritis, patient with local infection, systemic infection, and neuromuscular disorders, patients who are not medically fit for surgery. The criteria for evaluation of result are patient assessed by WAS and American Knee Society score, functional outcome measured by American Knee Society score, and radiological outcome measured by femorotibial angle and medial and lateral knee joint space. All patients are assessed pre-operatively and post-operatively at the end of 6 months. Pre-operative planning. Properly standing weight-bearing scanogram of the whole lower limb is taken. Pre-operatively visual analog scoring is done, and femorotibial angle measurement and medial and lateral joint space measurement is done. Pre-operatively American Knee Society score is taken. This is a weight-bearing radiograph of whole lower extremity before and after proximal fibular osteotomy, showing changes in the mechanical axis of femur and tibia. Technique of proximal fibular osteotomy. After proper painting and draping, measurement done from the head of the fibula, and the site of incision is marked 9 cm below fibula head, and 5 cm incision made along the marked line 6 to 9 cm from fibula head. Drill made at the proximal and distal site of the section of fibula to be removed. The 2 cm of the fibula is removed and incision is closed in layers. Follow-up: patient will be assessed on the basis of parameters femorotibial measurement, medial joint space measurement, lateral joint space measurement, and visual analog score and American Knee Society score. The results after PFO shows improvement compared to pre-operative findings. As seen by above data, all patients had significant pain relief and improvement of functions. So radiological changes were not very significant, but there is a definite opening of the medial joint space. Complications which can be seen with PFO: 2 out of 20 patients developed nerve injury leading to numbness on lateral side of the leg and foot, and 1 patient developed hematoma post-surgery. Discussion: PFO decreases the operative time, bleeding amount during operation, and drainage volume after operation, and shorten the full weight bearing time, and decreases the complication which can be seen with high tibial osteotomy and arthroplasty. PFO is a reliable, safe alternative to both high tibial osteotomy and unicompartmental replacement. The limitation of this study is small sample size, retrospective nature, and the short-term follow-up. The conclusion of my study is PFO relieves knee pain and improves joint functions in patients with medial compartment osteoarthritis, although there is a very limited data to conclude the effect in severe osteoarthritis. But the study shows obvious improvement in knee score in medial compartment knee osteoarthritis. Care should be taken to avoid later popliteal nerve injury. If it gets injured, there may be numbness in the foot post-operatively. And all the patients who underwent PFO, even after surgery, if symptoms are not resolved, these patients can still undergo total knee arthroplasty in the future. It becomes necessary. Thank you.
Well, Dr. Devendra, it sounds a very exciting kind of procedure, a very simple solution to a difficult problem. The difficulty is to accept it. I mean, the fibula is not a deforming force there. The varus which occurs is only because of the degeneration and wear and tear of the cartilage on the medial side of the joint. I fail to understand how a fibulectomy is going to correct the alignment and shift the mechanical axis. It's a bit difficult to accept that.
So actually, after fibulectomy, there will be a lateral shifting of mechanical axis and the equal distribution.
That is not the deforming force. I mean, that is not what is causing the deformity. I mean, doesn't even reach up to the knee joint. It finishes at the lateral tibial condyle. How is it going to shift the axis? I mean, I was open to other panelists as well. What do they think?
I think it's a procedure, Dr. Sharad, which probably is described mostly in China, and it's fairly low in hierarchy in terms of evidence. No, I actually read it a couple of years back and kind of gave it up because there are many ifs and buts into the whole procedure. In fact, you actually need to take care that you have to assess the tibiofibular joint first to see whether there is any arthritic component in that, and then need to decide the level of osteotomy. There are so many ifs and buts in this particular procedure. And most of the studies since 2015 are actually coming from China for this particular thing. It's a new topic. There is very less rehabilitation required, much less morbidity, much less expense. But as he's saying that some people do go into the HTO or in other forms of procedures which are done within 1 or 2 years. So you're very right. We really don't know. We need much more controlled multi-centric studies to come out with a plan for this.
I agree.
As a post-graduation, can you describe what are the proposed mechanism of how this osteotomy works? Too many cortices and competition of muscles.
Sir, it results in redistribution of the force from the medial compartment towards the lateral compartment, and
that is only one of the mechanisms. There are almost 5-6 mechanisms how it works.
And sir, it's other is that it changes the mechanical axis and slippage of the distribution of the forces.
And what about the competition of the muscles, which bring immediate relief after this osteotomy?
Sir,
what are the muscles I am talking about which compete with each other?
Sir, actually, there will maybe relaxation of the structures on the medial side.
Okay, now that's not the thing. Okay, thank you.
I think, Dr. Hitesh, we need much more data on this procedure before we even go doing.
Yeah.
Dr. Ravi, anything more in this session now we have?
No, sir, almost over. One person was left, which was the new entry. I have shifted him to the session B.
So we can conclude now?
So, yeah, sir, please. Yes, sir. Thank you so much.
I think we must congratulate to all the young presenters. They did very wonderful job. It's not easy to present at this level and to this audience. And please do not take our criticism too hard. I mean, it's just a discussion we are doing, and all are learning. I mean, we all learn from you as well. I mean, so please keep on doing it. You did a wonderful job, and we wish you all the best. Thank you.
Dr. Rajesh?
Yes, sir.
Yeah, please conclude this session.
Yeah. I'd like to thank all the panelists, Dr. Himanshu Kataria, sir, Dr. Shraddha Agarwal, sir, Dr. Hitesh Lal, sir. Thank you for giving your valuable inputs to the young researchers, and hopefully they'll definitely take some positives from this session. Now we'll start the next session. Over to you, Professor Dr. Ravi Johnson.
Yeah, thank you, Dr. Rajesh. So now we are moving to the second session. In panelists, actually, as the judges, Dr. Atul Vash, sir, is there. Dr. Hitesh Lal is there. Sir, Atul, sir?
Yeah, I am there.
Okay, sir. Hitesh, sir, are you there?
Hitesh, I am there.
So we are moving to first presenter. Our first
Dr.
presenter.
Ravi, I think Dr. Jatin Talwar also.
Dr. Jatin, sir. Sorry.
Thank you.
Yeah, Dr. Jatin Talwar is also there.
Yeah, thank you.
So, now we are moving to the first presenter, Dr. Lokesh Meena. Lokesh? Dr. Lokesh? please share your PPT. His topic is comparison of early functional outcome between lateral and posterior approaches in total hip arthroplasty. Dr. Lokesh, please unmute yourself first.
Good evening, sir.
Yeah, please share your PPT. Our next presenter is Dr. Rahul Garg. So Dr. Rahul, please be ready with your PPT. Please put it on presentation mode, Dr. Lokesh. Go ahead.
So is screen visible?
Yeah, it's visible, Dr. Lokesh. Please go ahead.
Good morning, sir. My topic is comparison of the early functional outcome between lateral and posterior approach in total hip arthroplasty. My moderator is Dr. Rama Avtar, HOD Orthopaedics, and Dr. Krishnan, Senior Resident. Introduction. Hip arthritis is common and hip osteoarthritis is a common and progressive joint disease causing pain, reduced physical function, and reduced quality of life. Total hip arthroplasty, it provides pain reduction and improves physical function and quality of life in most patients with age and stage hip osteoarthritis. It is well established that total hip replacement is one of the most frequent and most successful operations in orthopedic surgery. Thus, the reliability of the procedure is of major socio-economic importance. The operation should be effective in terms of pain relief, and should come along with the preferably short hospital stay and fast recovery. The overall function of the hip and patient satisfaction should be high. Aiming for a high percentage of patients with forgotten joint replacement, ability to forget artificial joint in everyday life, resulting in greatest possible patient satisfaction as soon as possible. Many different surgical approaches to total hip joint have been described. Currently, total hip replacement is most commonly preferred via posterior or lateral approach. Posterior approach. Posterior approach to hip is one of the most commonly used surgical approaches for hip arthroplasty. The posterior approach has the advantage of reduced operative time, no violation of gluteus medius and minimus, a low frequency of post-operative limb or abductor dysfunction. The disadvantage is higher cost rate and sciatic nerve injury, which is close to the field. Lateral approach. This was first described by Harding in 1982. A new surgical approach which takes advantage of the fact that the insertion of the gluteus medius to greater trochanter is by the strong tendon, which is wide in its anterior arc. Incision is made in line with the fibers of gluteus medius at the junction of the middle and posterior third of the muscle. Distally, the incision is made anteriorly in line with the fibers of vastus lateralis down to the bone along the anterior surface of the femur. The major changes described by Harding was to leave the posterior portion of the gluteus medius with its thickest insertion undisturbed from the greater trochanter. The advantage of this approach is the lateral approach can be extended and gives good exposure to both the acetabulum and femur, thus being suitable for primary and division operation. Main disadvantage is abductor muscle insufficiency is a common clinical scenario. Following a direct lateral approach, gluteal tendon splitting can lead to a post-operative tendon bug test. Material method. The study was carried out in Department of Orthopaedics, ESIC Model Hospital and PGIMSR, New Delhi for a period of 17 months from November 2018 to March 2020. 30 patients attending out OPD of ESIC Model Hospital and PGIMSR, New Delhi with all patients under primary total hip replacement as more than 20 years. Excluding criteria is age less than 20, age more than 80 years, dysplastic hip, neurological disease, bilateral hip movement, pelvic acetabular fracture. Patient medically unfit for major surgery were excluded from the study. Written informed consent regarding the surgery and study were obtained from all the patients. The target population was randomized using random number table into two groups, Group PA and Group LA. of 15 people each with similar baseline characteristics. Post-operative follow-up, all wounds routinely inspected on the 4th day and the time of suture removal on 14th day. Function of hip was assessed at 2 weeks, 3 and 6 months after surgery using Harris score and Trendelenburg test. Observation and results. We included 30 patients in our analysis, 15 from lateral approach and 15 from posterior approach. The group was similar with respect to age, p-value 0.79, gender, p-value 0.705. Temporal parameters were similar among the groups at the time point. At 2 weeks, there is negative Trendelenburg test in all the patients operated by the posterior approach as well as lateral approach. At 3 and 6 months, there is negative Trendelenburg test in all the patients operated by the posterior approach, while 13.33% patients operated with lateral approach had positive Trendelenburg test. No significant difference was seen in pain at 2 weeks, 3 months, and 6 months between posterior approach and lateral approach. Summary: a total of 30% were assessed on the basis of Harris hip score and Trendelenburg test. The age of the patient ranged from 20 to 65 years with mean age of 42.13 plus minus 11.51.
Dr. Lokesh, please wrap up in 30 seconds.
One patient had dislocation at 2 weeks, while a total of 2 patients had dislocation at 3 months. Both these patients had undergone THR by posterior approach, while no dislocation was noted in patients who underwent THR via lateral approach.
Wrap up. Yeah.
No significant difference was seen in pain at 2 weeks, at 3 months, and 6 months between posterior approach and lateral approach. No significant difference was seen in limb at 2 weeks, 3 months, and 6 months between posterior approach and lateral approach.
Compile, Dr.
Yes, sir.
You are already out of minute time.
Conclusion of my study: from this study, the functional outcome and Trendelenburg test held statistically no significant difference in the both lateral and posterior approach. Good surgical technique and awareness of the anatomy of the nerve supply are key factors in the preserving good abductive strength. Thank you.
Thank you, Dr. Lokesh. Sir, any questions for Dr. Lokesh? Dr. Atul, Dr. Hitesh, Dr. Jatin?
Yeah. Yes. पूछिए सर, आप पूछिए.
Atul sir, please.
Why you feel that there should be functional difference between the posterior and the lateral approach? Your study was for the functional parameters in both the approaches. What was your findings and why you feel that it should be different if the repair has been done properly? What you feel that what functionally patient will have deficiency in lateral approach or in the posterior approach?
In lateral approach, we have noticed the abducted positive Trendelenburg test in 2 patients, and in posterior approach, we have noticed 2 dislocations.
These are the complications. Like in posterior approach, you had sciatic nerve palsy also, foot drop. Then you had other, that is a known complication. But your paper was for functional difference. And have you seen the short and the long terms? Because initially there may be difference.
No, sir, no functional difference in both the approaches.
In the long term. Okay.
Yes, Dr. Hitesh, please. Any question, sir?
Let Dr. Jatin ask. He's our
Yeah.
guest.
Thank you, Dr. So, Dr. Lokesh, tell me one thing. This topic of comparison of approaches like posterior lateral, it's a vast topic, and many studies have been done, which have included sample sizes from 100, 200, 300 as well. Why do you think your study, which includes only 15 patients of each in both the groups, do you think your study is properly powered to come to any conclusion? It's a very small sample size.
No, sir, there is a small sample size, so there is no difference in functional outcomes.
So you think it's a good thing to have such a small sample size to comment on such a big thing about approaches?
No, sir.
So that means your study is practically grossly underpowered, and statistical significance you cannot rely upon. Can you rely upon your findings which you have found?
Is a sample size is very short, so we can not rely.
How did you decide? How did you
There
decide?
is so many studies which included 500, 600 patient, and duration of the study is more than 2 years.
So how is your study adding to our current knowledge of literature and orthopedics? Tell us that. It actually doesn't add anything, right? Yeah, my question is over. Please carry on.
Okay.
Thank you, Dr. Lokesh.
So now we are moving to next speaker, Dr. Rahul Garg. Rahul, are you ready
Yes,
with
sir.
your? Yeah.
Yes, sir.
His topic is quadriceps muscle strengthening exercises in varus and neutral aligned knees in osteoarthritis, short-term functional and radiological evaluation. Dr. Rahul, please share your PPT.
Sir, is my PPT visible?
No, not yet.
Sorry, sir. Sorry.
Dr. Shashank, get ready with your PPT. You are the next speaker.
Sir, is my PPT visible?
Yeah, please go ahead.
Yes. Good evening, everybody. My name is Dr. Rahul Garg. I'm a postgraduate resident in Maulana Azad Medical College. The topic of my presentation is a comparative study on the effects of quadriceps muscle strengthening on the progression of disease in medial compartment osteoarthritis in knees with or without varus malalignment under the guidance of Dr. Manoj Kumar sir. As we know, quadriceps strengthening exercises play a pivotal role in reducing pain and improving function in OA knees and being practiced for years, but all patients do not benefit equally from them. Hence, a pointed inquiry was undertaken on why, despite the beneficial effects of quadriceps strengthening exercises, yet there is a disease progression that continues to occur. A contraction of quadriceps muscle dynamically stabilizes the knee through a compressive force that passes through the knee joint. Varus malalignment causes concentration of this compressive forces on a medial compartment of the knee, which sets into motion a vicious cycle of self-deforming effect with every cyclical physiological loading of knee and repetition of quadriceps strengthening exercises. The aim of our study was to compare the effects of 12 weeks of quadriceps strengthening exercises on pain and function of knee in patient of medial knee osteoarthritis with or without varus malalignment. We did a comparative observational study on 32 patients presenting us with medial compartment osteoarthritis within an age group of 40 to 70 years who were fully ambulant and presented to us with duration of 6 months. We did not include patients with infective etiology, post-traumatic osteoarthritis, ligamentous instability, or flexion deformity of greater than 15 degree. The 32 patients were divided into two groups on the basis of anatomical femorotibial angle, with the angle ranging between 176 to 180 degree were included in the neutral group, while the angle of greater than 180 degree was included in the varus group. Both groups contained 16 patients, and both the groups were subjected to 12 weeks of quadriceps strengthening exercises. The patient was started on 20 repetitions of isometric exercises and 10 repetitions of isotonic exercises, muscle contraction for 10 seconds. Thereafter, there was increment of 2 repetitions in both exercises regime every fortnight and an increase of 0.5 kg of weight in isotonic exercise every month. The quadriceps strength was measured using a handheld dynamometer, precise industrial push-pull gauge. The patient was assessed at recruitment and after 12 weeks of quadriceps strengthening exercises for clinical and radiological outcome. The clinical outcome measures were VAS score, medial patellofemoral joint tenderness, step test, stair climb test, time up and go test, WOMAC score, and IKDC score. The radiological measure were the lateral femorotibial joint separation, the anatomical femorotibial angle, the hip knee ankle angle, and the horizontal distance from the center of knee to the Mikulicz line. The following table shows the demographic detail of the patient at recruitment of both the groups. With a mean age of 47 years in the neutral group and a mean age of 54 years in the varus group, with male is to female ratio 1:3 and BMI ranging from 23.5 in neutral group to 23.7 in the varus group. The quadriceps strength, the mean quadriceps strength in the neutral group was 33
25.63 newtons as compared to the varus knee, which was 25.25 newtons. The following table shows the clinical and the radiological outcome measures which were recorded in both the group at the baseline. The following slide shows the comparative analysis of outcome measures in the neutral group. As depicted by this graph, there was significant improvement in pain and functional outcome measures after 12 weeks of quadriceps strengthening exercises, which was supported by our p-values. Also, this graph shows that the some of the patients in the neutral group had a radiological progression of disease. In comparison, the varus group, some patients although showed the improvement in pain and functional outcome, but the improvement in a number of patients that improved in the varus group were less as compared to the neutral group. In same thing, the patient that showed radiological progression of disease were more as compared to the neutral group after same period of quadriceps strengthening exercises. Hence, our study showed that the quadriceps strengthening exercises reduce pain and improve functional status, which were better with neutral alignment, as the abnormal afferent signals and the exacerbating knee pain due to greater patellofemoral joint compression in varus malaligned knees leads to decreased quadriceps contraction, leading to less functional gains. Also, the radiological parameters were at variance with the functional parameters. The varus malalignment leads to alteration in the line of action of quadriceps muscle. The greater strength leads to greater compressive force along the altered line of action, leading to progression of disease. And the sample size of 32 patients and the period of follow-up of 12 weeks were relatively less to reach the statistical significance and detect the correlation between malalignment and outcomes, and also to find out the cutoff of varus beyond which quadriceps strengthening exercises would be harmful. We conclude that the benefit of quadriceps strengthening exercises on pain relief and functional improvement were better with the neutral group as compared to varus group. Also, the radiological deterioration were more significant in knees where varus malalignment was already present. Thank you.
Thank you, Dr. Rahul. Please unshare your screen.
Yes, sir.
Any questions, Atul sir and Jatin sir?
Dr. Rahul.
Yes, sir.
Your chart was showing that grade 1 and grade 2 were non-neutral alignment, and grade 3 and grade 4 were the varus deformity.
Yes, sir.
So do you think that grading was more important in your final results which you are showing?
So basically, the study was more based on the angles. The Calgan-Lawrence scale was used just to grade the patient who were presented to us with bilateral symptoms. So we took the knee which was more symptomatic, and the patient who were presenting to us with equal symptoms in both the knees, the Calgan-Lawrence scale was used to select the study knee.
In functional improvement, we all have seen, but how do you explain the radiological changes?
So the radiological changes in the neutral group?
Both groups you have shown.
So yes, sir. So the explanation for that is the osteoarthritis leads to the concentration of that force on the medial compartment. It shifts the Mikulicz line towards medially. So so there is more load that presents to the medial compartment on each cyclical physiological loading that the patient walks, and also after the quadriceps strengthening exercises that causes more deterioration of the medial compartment as compared to the lateral compartment. And also in my study, we loaded the quadriceps strengthening exercises with increment of weights after every month. So that also led to the more load in the medial compartment. So that would be the possible explanation, although the study size and the follow-up period was less to comment on the final results.
Oh, Dr. Rahul.
Yes, sir.
Tell us what happened to the patients who had good radiological pictures. Good radiological pictures belonging to your neutral group, but who were having more pain at the startup of your surgery.
So, the patients who had a good radiological pictures and were complaining of medial joint line pain, they improved. They improved on the symptoms and and functional outcomes. And also there was no radiological deterioration seen after 12 weeks. maybe we need to follow up that patients after a year or two to see if they are progressing on that parameters or not.
You do need to follow them for a period more than 6 months, definitely. And
Yes,
at the startup of your surgery, if your patient is having more pain as per the visual and scale, you have used a VAS scale for that.
yes, sir. VAS scale.
So if your patient is having grade 6 pain,
yes,
so
sir.
do you recommend quadriceps strengthening exercises directly to start with?
Yes, sir. Yes, sir. So
Pain, grade 6 pain.
Yes, sir. I have seen that if the patient has come to me with grade 6 pain and he is radiologically normal with like the angles were not beyond 180 degrees, anatomical femorotibial angle and the Mikulicz line had not shifted greatly. They were significant improvement after 12 weeks of quadriceps strengthening exercises. So that I have seen personally in 2 of my patients. Although sir, I would like to do my study on more patients, which is I'm following up for the follow period. So.
Yeah, because you have yourself said the limitations of a study were a very small sample size, which
yes,
I completely agree. Okay, yeah. Over to the next panelist, please.
Okay, thank you, sir. Now our next speaker is Dr. Shashank Rauza. His topic is evaluating the endurance of back muscles and comparison between various test designs. Dr. Shashank, please share your PPT.
Sir, is it visible?
Yeah, is it visible? It is visible. Please go ahead.
Good evening, everyone. I am presenting my paper on evaluating the endurance of back muscles and comparison between the various test designs. I move on to the introduction. The muscular endurance is defined as the ability to produce continuous sub-maximal work over a long period of time, or the ability to sustain the effort. It can be divided into 2 categories, a general and a specific endurance. Endurance training is also known to affect the cardiovascular system by enhancing the maximum aerobic capacity, which is also known as the VO2 max. Till date, the most popular method for endurance testing is the Sorensen's test, which is a static test with no rhythmic contractions of the muscle. Now, Sorensen's test, we described the Sorensen's test. In 1984, Beijing Sorensen described the test where the subject lies in prone position with the lower body fixed to the examination table and the upper body extending beyond the edge of the table. The test consists in holding the upper body horizontal as long as possible. So as we can see in the image, now we evolved 3 reliable tests for measuring the endurance of the back muscles by performing the dynamic tests similar to those of the daily living activities, incorporating certain level of cardiovascular workup as well, which measures the endurance in a holistic manner. So our 3 new test designs were, the first one was the inclined spot jogging as seen in the first image. The second was inclined pelvic push-ups as seen in the second image. And the third one was the pelvic bridging test as seen in the third one. So the aims and objectives of the study to evolve the various reliable test designs for measuring the endurance of back muscles and to have the baseline data for endurance. Also, we calculated the VO2 max values, and also we compared these tests among themselves and along with the prevalent ones, which was the Sorensen's test. Now the methodology. The place of study was the Department of Orthopaedics of Loknayak Hospital. It was a cross-sectional study for a duration of 1 year. Sample size was 50. Now the inclusion criteria was healthy young individuals between the age of 20 to 30 years were selected with a BMI of 18.5 to 22.9. I excluded the patient with spinal deformities such as scoliosis or exaggerated lordosis, patient with a backache, associated hip and pelvic disorders, any patient with spondylolisthesis or spinal fractures, be it acute or chronic. I also excluded any patient who was not able to perform the Sorensen's test or for a duration of less than 60 seconds, or any patient with a cardiovascular or respiratory disorder. They were excluded as well. Now the outcome measures were the primary outcomes and the secondary. The primary outcomes were endurance values of the back extensors, which were measured in seconds, and the reliability of these tests. As all these new tests were repeated after a duration of 1 week in all the subjects to check for the retest reliability. The secondary measure was the VO2 max or the maximum aerobic capacity values as calculated by dividing the maximum heart rate by resting heart rate and then multiplying it by 15. Now the results. The mean time duration of Sorensen's test was 155.96 seconds, while the inclined spot jogging was 110 seconds. Inclined pelvic push-ups was 110.52 seconds, and pelvic bridging test was 88.84 seconds. The VO2 max values were important, and as we can see, the maximum values for maximum aerobic capacity was seen in the inclined spot jogging of 25.80, while the minimum values were seen in the Sorensen's test, which was 20.46. I also used scoring in these patients where patients were asked to give score out of 10, where 10 was the test, 10 denotes the most comfortable test, and 1 denotes the most difficult one. So an average score of 5.86 was given to the Sorensen's test, which was the minimum, while the maximum score was given to the inclined pelvic push-ups, which was 8.14. Now, this is the graph which represents the mean time holding. The maximum time holding was seen for the second application of the pelvic thrusting, which was 176.5 seconds. Now we move on to the VO2 values, and the VO2 max values were the maximum seen in the first application of spot jogging, inclined spot jogging, which was 25.8 seconds. Balanced and healthy functioning of the musculoskeletal system requires that muscles be able to exert the force or torque, which is known as the strength, or resist the fatigue, known as muscular endurance, and also to move freely throughout a full range of motion, which is known as the flexibility. Any imbalance among these three criteria, the one strength, endurance, and flexibility, it is likely to produce the reduced capacity of body part. Now, the trunk extensors are thought to serve a postural function, exhibit a high proportion of fatigue-resistant fibers, and have shown to fatigue more with the stationary activity, that is like sitting, while as compared with the non-stationary activity of repeated contractions like walking. Now,
your 5 minutes are over.
Any person with low isometric endurance.
Wrap up in last minute.
Yes, sir. Yes, sir. With low isometric endurance of trunk extensor have been reported to show more serious attacks of low back pain. Evaluation of muscle performance encompasses both strength and endurance. The muscular strength is the amount of force that a muscle or muscle group can voluntarily exert in one maximal effort, while the endurance is defined as the ability to perform a repeated contraction over a certain level of time. Now, I compared these tests in the terms of test-retest reliability. I performed all these tests after a duration of 1 week. So, inclined spot jogging had a duration of 110 seconds in the first one and 102 seconds in the second application, while the inclined push-up has 88.84 seconds in the first application and 93.4 seconds in the second one. With the pelvic bridging has 170 seconds in first application and 176.43 in second application. All these correlations were statistically significant. Now, in terms of maximum aerobic capacity, Sorensen's test has the minimum of 20.46, while the inclined push-up has the maximum amount of VO2 max involvement, which is 24.92. Now, in when I compare,
time is over. Wrap up in 30 seconds.
Yes, sir. Average score of 7 was given to the spot jogging, while 8 score was given to the Sorensen's test. Sorensen's has the minimum of 6 score. The low scores in case of Sorensen's test might be attributed to this cumbersome posturing test, tight belts used to hold the body to a bench. Take-home message is the dynamic endurance tests are more reliable, involve the cardiovascular system, and correlate with the normal human activities of daily living. While the inclined spot jogging appeared best in terms of reliability and VO2 max, and can be a good tool to measure endurance of back muscles. Thank you, sir. That's all.
Thank you, Dr. Shashank. Atul sir, Jatin sir, questions please.
Not from my side.
Okay. Atul sir?
No, nothing.
No questions, sir?
No.
Okay. Thank you, sir. Now we are moving to next speaker, Dr. Devendu Vishwas. Dr. Devendu, please share your PPT.
Sir. Sharing my screen now, sir.
Yeah.
Is it visible, sir?
Yeah, please go ahead. Just stop your second device.
Good evening, everyone. Myself, Dr. Devendu Vishwas, third year PG in Department of Orthopaedics, MAMC, under guidance of Dr. V.K. Gautam, sir. I'm going to present the topic, comparative evaluation of platelet-rich plasma versus corticosteroid injection in rotator cuff tendinopathies. Localized spinous tendinopathy, with or without an associated cuff, there is a common reason of shoulder pain. It represents a spectrum of cuff involvement from mere tendinosis to tears, which can be either partial thickness or full thickness. Most commonly used treatment modalities for rotator cuff tears include non-operative methods, which include exercises to regulate the scapular kinematics favorably, or through steroid injections injected locally into subacromial space. While operative treatment allows primary repair to be performed, but the repaired tissue is often of poor quality and frequently degenerates. Also, these procedures are carried out under general anesthesia, which carries its own risk. Recently, there is an upward trend towards the use of biologicals like platelet-rich plasma in chronic soft tissue problems, including rotator cuff tendinopathy. Since PRP has healing properties at molecular level, it is likely to repair the damaged tissue or tendon. Hence, in this study, we propose to evaluate the effectiveness of PRP in patients with symptomatic rotator cuff tears, comparing it with the effectiveness of steroid injection by keeping the patients under follow-up of 3 months. Our study was a randomized control study, and the method of randomization was head and tails method conducted in Department of Orthopaedics, MAMC. Sample size was of 20 patients, and we included symptomatic supraspinatus tendinopathy patients, rotator cuff tears, either partial thickness or full thickness, that were not responding to standard conservative treatment, and patients were aged between 18 to 80 years. We excluded all the tears which were secondary to fracture or dislocation, all the tears that underwent prior surgical intervention, patients with pre-injection platelet count of less than 1,25,000, and shoulders with pre-existing arthritis, ongoing infection, or entrapment neuropathies. Patients were randomly divided into 2 groups, one group in which single injection of corticosteroid was given, and the second group in which single injection of PRP was given. Patients were followed up every 3 weekly for 3 months. Every 3 weekly, pain assessment was done using VAS score. Functional assessment was done using constant Mully score, and radiological assessment was done by comparing the pre-injection MRI with the MRI done at 3 months. Procedure was carried out under all aseptic precautions, orthopedic, OT, or OPD, and subacromial injection was given to have the desired effect. Post-operatively, all the patients were advised to give rest to the part for few days, use ice packs in case of pain, and NSAIDs were strictly avoided in these patients since they are known to decrease the quality of platelets. Coming on to the results, this line diagram is showing the comparison of VAS score between both the groups, with blue line depicting the corticosteroid group and the orange line depicting the PRP group, in which we can see that VAS score is significantly dropped from pre-injection status to after 3 months, and both the groups show comparable results, and the final result was not significant between both the groups. The only difference which was significant is that the group with corticosteroid injection showed early improvement as compared to the PRP group. Coming on to the comparison of constant Mully score, which was the functional score we used. In this also, both the groups showed significant improvement in the function, but the final result was comparable and not statistically significant. But the corticosteroid group showed early improvement at the 3 weeks, where PRP was still moving on. The final improvement in constant and Mully shoulder score was more with the PRP group, but such difference was very little statistically. Coming on to the imaging, out of 10 patients in the PRP group, 2 patients showed evidence of supraspinatus tendon healing, while in 8 patients there was no significant difference as compared to the pre-injection MRI. While in steroid cases, none of the patients showed supraspinatus evidence of healing, but there was evidence of reduced bursitis in 2 patients at 3 months. The purpose of our study was to evaluate the effectiveness of PRP and compare it with that of steroid.
Dr.
So
Devendra, your 5 minutes are over.
VAS score in corticosteroid group fell from 7.1 to 3.3, and PRP group it fell from 6.6 to 2.8. But by there's important finding was that by the end of 3 months, patient reported slight worsening of VAS score in the steroid group, but it was still better than the pre-injection status. But constant and Mully score also showed the same trend. The difference was only statistically significant at initial 3 weeks, but insignificant at 6 weeks, 9 weeks, and 12 weeks. Mean improvement was found to be more in the PRP group, but such difference was statistically insignificant. Studies conducted by Barreto et al., VC Sangdon, DH Ibrahim et al. Showed similar functional outcomes with steroid and PRP, with no significant difference between both the groups. On imaging, as told earlier, 2 patients in steroid group showed evidence of reduced bursitis, but none of them showed evidence of healing, while in PRP, 2 patients showed evidence of supraspinatus healing. A similar study was conducted by Shams et al., in which 20 patients in PRP and 20 in corticosteroid group was taken, but he found no statistically significant difference on conducting MRI. While a study conducted by VC Sangdon et al., in which ultrasound was done to find evidence of healing, but there was 11 patients complete healing was seen. So we conclude by saying that corticosteroid injection provide quick pain relief and significant improvement in function and is a useful conservative means of treatment, but recurrence of mild pain was seen in few instances. While PRP provides a delayed but more sustained improvement in function, and radiologically PRP was found to promote tendon healing. Our take-home message would be that PRP is autologous in nature with minimal side effects and hence can be used as a successful alternative to corticosteroid in treating tendinopathies. Thank you.
Thank you, Dr. Devendra. You can unshare your screen now.
Yes, sir.
Atul sir, any questions?
In these studies of PRP, I just want to ask you how you standardize, how do you see the quality control of CR, because the concentration of the platelet is more important.
Yes, sir.
And whatever you centrifuge and whatever you inject may not be same in for all the patients you are. So how do you do the quality control in these PRP patients? Because the result will be different if the number of platelet is not up to the which is required in PRP.
Yes, sir. So for that, we before injecting the PRP, we ask the patient to come one day prior to take blood samples for getting the pre-injection platelet count of the patient. And after preparing the PRP, before injecting into the patient, we took another sample from the prepared PRP, which we sent for the analysis. But all those patients in which we found that concentration was not adequate, like in which the concentration did not reach up to 2.5 times the initial count, we excluded them from the studies. So we included all those patients in which 2.5 to 3 times of concentration was seen.
Thank you.
Yeah, Dr. Devendra, I have lots of questions in my mind, but I'll quickly sum up these. First of all, your age group which you have selected is 18 years to 80 years.
Yes, sir.
Which is pretty wide if you consider your shoulder problems, because the etiology of problems in 18 years, 20 years, 30 years will not match with etiology of your tendinosis in 80 years old male. So that is probably one big lacuna right here. Another thing, just tell me that you are giving injection in subarachnoid space.
Yes, sir.
What do you mean by that? You are just leaving injection in the space, that's all?
Sir, after following the surface landmarks, we injected it into the subacromial space only, not into the joint area, sir. By clinical palpation only, without using any ultrasonic guidance.
How do you expect the PRP injection to heal the tendinopathy, tendinosis, or a tear? If that is the case, if you leave the injection in the subarachnoid space, have you read of any such that?
Sir, all these studies which we, on the basis of which we started this study, in every study, either they use clinical subacromial injection or ultrasound guided subacromial injection. But in every study, subacromial injection was used, sir.
But there was no method for you to ensure that your injection has reached the right space. As Dr. Vash said, the concentration of PRP is also very important.
Yes,
and the site where you inject it is very important. Otherwise, you won't have an optimal effect. Another thing is 3 months follow-up. Is a very small follow-up for you to evaluate PRP.
Yes, sir, it is one of the limitations of our study that follow-up time was pretty less. We required at least 6 months of. Sir, I'm still keeping the patients under follow-up, so hopefully, sir, I'll get longer.
To a conclusion of healing, you need to have a good follow-up. Otherwise, you will not know how PRP is acting.
Yes, sir.
Right.
Yes, sir.
What are the next panelists, please?
Yeah, thank you, Dr. Devendu. Thank you, Jatin sir.
Thank you, sir.
Our next speaker is Dr. Ekjot. Please share your PPT.
Yes, sir.
His topic of presentation is evaluation of patellofemoral malalignment in a chronic anterior cruciate ligament deficient knee.
Can you see, sir?
Yeah, please. No, we are not able to see. Just please share your PPT.
Just share it.
Yeah, it's coming now.
It is coming?
Yeah.
Is it on, sir?
Yeah, presentation mode, please. On.
Okay, just a second. Yes, sir. Is it on?
Please go ahead, Ekjot.
Yes, sir. So I'm Dr. Ekjot Singh Arora. I'm postgraduate third year from Central Institute of Orthopaedics, Safdarjung Hospital. My topic is evaluation of patellofemoral malalignment in a chronic anterior cruciate ligament deficient knee. So the ACL is one of the major ligaments stabilizing the knee joint. It contributes significantly to the stabilization kinematics of knee joint because it resists the combined motions of anterior tibial translation and internal tibial flotation. Injury to ACL can alter the tibiofemoral kinematic balance and can cause abnormal biomechanical behavior, which puts the patellofemoral joint at the risk of secondary injuries. In the Indian literature, there is a paucity of patellofemoral alterations in the ACL deficient knees, especially in Indian population where squatting and ground level activities are a common routine. Hence, my study aims in the assessment of these alignment in chronic ACL tears, because better understanding of the phenomena may help us in improving our therapeutic treatment and rehab protocols in patients with ACL injuries. Aim I try to study and prove this malalignment by the means of radiological parameters, that is X-rays. Case control study was done in 35 patients with already diagnosed unilateral ACL injury, which was confirmed by physical examination and MRI. MRI showed exclusive unilateral ACL tears without any other soft tissue injury. The injured knee was taken as the case, and the contralateral normal knee was taken as the control. 4 radiographs were produced for each patient, 2 on each knee when the lateral view was taken, 30-degree flexion, and two axial radiographs of each patella covering both the knees with the patient position spine and the beam at 30 degrees horizontal with knees flexed at 45 degrees horizontal. 3 patellofemoral parameters radiographic were recorded, which were taken from their respective papers and studies. Number 1 was the Merchant angle of patellar congruence, which measures the extent of lateral displacement of patella with respect to trochlear circles. It was measured on the axial radiographs of patella. Second, Lorentz angle of lateral inclination of patella, which was also measured on the axial radiographs. It is a measure of lateral tilt of patella. Third, measured on the lateral view of X-ray, the patellar height, which was measured as Caton-Deschamps patellar height index. It measures the extent of cranial or caudal displacement of patella. Starting with, coming in a few slides, it's the X-ray from the study, and as the alongside is the X-ray of my patient. So in the lateral view, Caton-Deschamps patellar height index, it is the ratio of distance of the articular surface of the distance of articular surface of tibia to the lower articular facet of patella and the length of the articular margin of patella. Normally it is about 1.0, greater than 1.2 is patella alta, less than 0.8 is patella. Same is my patient. I've calculated the distances. Second parameter, patellar Merchant's angle of patellar congruence. It is taken on the lower left side by seen as Merchant's view. 45 degrees the cassette and 30 degrees the beam. It is defined as the angle between 2 lines. One line which bisects the sulcus, and second line which joins the point on the sulcus with the lower border of patella. Third is the Lorentz angle of lateral inclination of patella. It is the angle between a line joining the medial and the lateral femoral points and another line along the lateral facet of patella. Given alongside is one X-ray of my patient. So I did around 35 patients. I took the parameters and I calculated that the Caton-Deschamps patellar height index has a mean value of 0.95 in the abnormal knee, that is the ACL deficient knee, whereas mean value is in the normal knee is 1.01, plus minus 0.05. The Merchant's angle of patellar congruence has mean value of 12.66 degrees in ACL injured knees and 5.69 degrees in the contralateral normal knee. The Lorentz angle of inclination is 8 degrees in the ACL deficient knee and 11 degrees in the contralateral normal knee. Based on this, I infer and conclude that knees with chronic ACL tears have lower patellar height. They have greater lateral displacement of patella and greater lateral patellar tilt, and thus they affect the patellofemoral joint. Hence, based on this snapshot study, we can conclude that the ACL tears have to be treated early, because if a knee lands up into chronic ACL tear, they'll get these X-ray, these patellofemoral joint malalignments, and hence it can affect the patellofemoral joint. Thank you.
Thank you, Dr. Ekjot. We in time. Atul sir, any questions?
Ekjot, what do you think that because of the ACL deficiency, this patellofemoral disorientation is there? What is the basic cause?
So the anterior cruciate ligament prevents the tibial translation and internal fluidation. It prevents the so if a knee has deficient anterior cruciate ligament, so the mechanics of the knee change, and hence it affects the joint.
Elongation of the patellar tendon mechanism. Okay.
Yes, sir.
And because of that elongation, there is a tilt. So do you feel that if we repair this ACL, this patellofemoral, all the disorientation of the patellofemoral will be corrected? Or do you feel that there are few things which are left behind after ACL reconstruction also?
So,
what is the clinical significance of this? What early because your study
The
is
study was basically snapshot study. It did not follow up the patients. It was a snapshot study. It was not a follow-up study. So I could not conclude whether any parameter is. I did not follow it after the reconstruction of the patient. मतलब reconstruction के बाद मैंने follow up नहीं किया. It was just a snapshot study. So I just concluded कि the changes are there in the chronic ACL tears, and if repaired, they can be, they may or may not be.
These are the known facts after ACL, the chronic, especially the ACL deficient knees. But clinical significance of this, and what is the main aim of this study, that how to early why you will be diagnosing it early to prevent what, that was I was wanted to. This is anatomical changes which definitely we all found.
There have been studies which prove that chronic ACL tears may follow the knee lands into OA also because of bad malalignment and tagging of patella, sir.
Yeah.
Dr. Hichod, I completely agree with what Dr. Atul Vaishya is asking you. Basically, the thing is, for any recommendation to the literature and to your peers, you need to have a comparative group, like, because this is one patient, one limb is control, other limb is case, all right. And moreover, you know what, when there's the last slide, when you have shown 3 indices, the values, how have you evaluated that value was statistically significant? Because we have not seen any method where you have.
There is a study by D1 scholars from Brazil. I did not show it, I'm guilty of that. I did not show the comparison in the slides, but I've done it. It shows significant.
Because you have to definitely mention that whether your reading was statistically significant or not. It might have come just like that, you know. Whether it was significant or not, was it just by chance?
Yes, sir. I forgot.
That we have not.
I forgot to include
You
graphs.
always insist on the strengths of your studies.
Yes,
one of the strengths could have been that if your result was statistically significant.
Yes,
and the second thing is, definitely with post-operative, you should go back to these indexes.
Yes,
and then you see that what has happened in patients in whom you have operated. Right? They are just my 2-3 suggestions which you can change for it to get published in some good journal. Yeah, thank you. Thank you, John.
Thank you.
Thanks, Ajot. Our next speaker is Dr. Kailash Meena. Kailash, Dr. Kailash, please share your PPT. His topic of presentation is a comparative study on the effects of selected yoga postures and conventional physiotherapy exercises on sagittal spinopelvic balance in patients of non-specific chronic low back pain.
Sir.
Dr. Kailash?
Sir.
Please share your PPT.
Yes, sir. Am I visible?
No, your screen is not visible at this time. Yeah. Just put it on presentation mode and go ahead.
Yes, sir. Good evening, leads. I'm Kailash from Maulana Azad Medical College. My topic of presentation is a comparative study on the effect of selected yoga posture and selected conventional physiotherapy exercise on sagittal spinopelvic balance in patients of chronic non-specific low back pains. The sagittal balance of the spine is in normal limits when a plumb line from the center of the body of C vertebra lies within plus minus 2 centimeters of the sacral movement. Then more expenditure of energy and high demand of dynamic and stability are required to compensate for the abnormal sagittal balance. And the abnormal sagittal balance usually results in the pain and functional disability in the spine. So an association between the loss of lumbar lordosis and anterior shift in the sagittal vertical axis and the development of symptomatic back pain and degenerative changes was described by Rosley in 2005. The lack prevalence of the low back pain is reported to be as high as 84%. So the effect that yoga posture and conventional physiotherapy back exercise may have not been examined on the spinopelvic balance. So keeping in line with the ever-growing interest of the orthopedic surgeon and spine surgeon, the yogic posture and as a reliable and reproducible modality of the treatment for non-specific chronic low back pain, a pointed inquiry was undertaken to examine the correlation between low back pain and sagittal spinopelvic balance and the effect of various yogasana. Accordingly, a comparative study was conceived keeping the conventional physiotherapy exercise in the second arm of the study. The study design was non-randomized study and there was 30 patients, 15 in each group at Maulana Azad Medical College and associated Loknaik Hospital. Patient of non-specific chronic low back pain with the age group of 18 to 16 years and a score 4 or more on the Roland Morris disability scale were included in this study, and excluded patient with a spinal deformity, spinal fracture, spinal tuberculosis, infection of the spine, or previous spinal surgery. The patient the patient having contraindication for radio exposure were also excluded from the study. The criteria of selection of the cases were on the basis of odd and even number in both the groups. Group A was treated with the posture. For each session lasted for 45 minutes for 12 weeks and was conducted by a qualified yoga instructor. The yoga asana were included in this study was in different postures. Standing yoga posture, asana, were included. In sitting posture, Sasankasan and Marijarasan, well in prone posture, Bhujangan, Labasan, Makrasan, and in supine yogic posture, Pasan, Paunasan, and Markatasan were included. In group B, still treatment in the form of conventional physiotherapy exercise at the physiotherapy department at Maulana Medical College. Each exercise was done per day.
Your sound is not clear.
Yes, sir. The following exercises were included: bridge exercise, prone alternate straight leg raise exercise, and back extension in lying position. The Roland disability scale, modified Oswest low back disability scale were measured at the time of recruitment, 3 weeks, 6 weeks, and 2 weeks follow-up. And following radiological outcome measures were measured at C-shape line, sacral slope, sacral inclination, numbers, sacral angle, and sagittal vertical axis. The results were so updated in this format, and we can see that in declining trend in the walk or modified spinal Morris disability score in both the groups, but greater improvement was observed in the yoga group. As we can see in graphic representation, in both the groups the declining trend is there, but a more declining trend in yoga group. Same tabulation was calculated for radiological parameters, and with the help of the thoracic lumbar lordosis and sagittal vertical axis saw significant changes in the yoga group. Score, Roland Morris score, so a declining trend in both the group, but more in yoga group. And after completion of 12 weeks follow-up, 14 out of 15 patients attained neutral sagittal balance in yoga group and 13 in physiotherapy group. So significant parameter revealed no statistically significant changes after the conventional exercises.
Dr. Kailash, your 5 minutes are over. Please wrap up it in last minute.
Finding in the study due to insufficient power. The sample size taken only 30 patients, so sagittal spinopelvic alignment cannot show changes in this patient, and we can conclude that significant radiological outcome measures were observed in yoga group at 12 weeks in the patient of chronic non-specific low back pain, and most of the patients stopped using pain medication after starting the yoga therapy. and there are few dropouts in yoga groups. So these observations provide sufficient ground for clinicians to continue to explore the role of yoga in management of non-specific chronic low back pain. Thank you.
Thank you, Dr. Kailash. You can stop your slide. Atul sir, any questions, sir?
We all know that the exercises plays an important role for treatment of these chronic backaches. But what I want to say is his topic of spinopelvic balance. I think the study group should have been more in the aged group, because this is more important for the aged population, which loses this balance and has a progressive deterioration in its strength of back muscles, causing the non-activity of these daily living activities of daily living. This 18 to 60 groups which he has studied, definitely as a treatment, we all know that these parameters will be there. Whatever figures he has given, they can be explained.
Jatin sir?
Yeah, Dr. Kailash, why did you not randomize your group? You have mentioned it that you have that study design is non-randomized comparative study. Why did you not want to randomize? Because I think without the randomization, you will introduce lots and lots of selection bias here. Why is it so? Any specific reason for that?
So no particular reason for that, but we choose patient on the odd and even basis only. And no other randomization method were.
If there is no particular reasons, then you probably needed to randomize your study. Otherwise, without that, you cannot insist on your statistical significance. You have already introduced lots and lots of selection bias. And the biggest confounding factor is that only. So that leaves your study unreliable. Many of your slides I could not hear because the audio was quite cracking. So I cannot comment on that. So maybe we can go to the next candidate.
Okay, sir. Thank you, sir. So our next speaker is actually, we are taking Ashwani Verma. And after Ashwani, we will move to Siddharth. Ashwani?
Yeah, thank you, sir. Good evening, everyone. Myself, Dr. Ashwani Verma, PG third year in the Department of Orthopaedics in Dr. RML Hospital. First of all, I would like to thank all of my seniors to give me the opportunity to present my work here. My topic is proprioceptive function of knee after preservation of posterior part of stump in arthroscopic anterior cruciate ligament reconstruction. In ACL deficient knees, loss of proprioception is demonstrated by altered gait patterns, and it has been observed that these gait changes are due to changes in proprioception and they are not due to mechanical instability that follows the injury. Functional issues like proprioception compensatory mechanisms are recent phenomenon, and the role in achieving postoperative stability is now coming into the light. In ACL reconstructed knees, proprioceptive feedback can be an important factor pertaining to functional outcome and in subjective feeling of stability. In ACL injured knees, loss of proprioceptive function along with gait patterns enhances mechanical instability, which leads to secondary injury. So in order to achieve good function, restoration of anatomic and proprioceptive function is required. So the lacuna in existing knowledge is that preserved stump of ACL in stump preserving ACL reconstruction, whether it causes improvement in proprioception or acceleration of vascularization or ligamentization of the graft, as compared to standard stump sacrificing techniques, the role is controversial. Aim of my study was to assess the proprioceptive function of knee after preservation of posterior part of ACL tibial stump in arthroscopic ACL reconstruction. So I have conducted my study in Dr. RML Hospital from the period of 1st October 2018 to 31st of March 2020. And I included 20 cases in my study. So all the patients with 18 to 50 years of age with the ACL injury and other normal knee were included in the study. All the patients who had bony avulsions of ACL ACL injury with associated other ligament injuries, cartilaginous lesions, meniscal injuries, intra-articular fractures, ACL tears in osteoarthritic knee, history of previous knee surgeries were excluded from the study. So all the patients were included in, who were included in the study were clinically examined as per the proforma, and patients' proprioceptive function then were measured using 3 clinical tests. The first test was reproduction of passive positioning test, and in this test I made the patient sit on the couch, examination couch, and he was blindfolded, and I passively flexed the knee at 4 angles, first at 30-degree angle, then 50, then 70, then 10 degrees, and then I asked the patient to reproduce the same angle with the injured leg or injured knee, and the angle difference was measured preoperatively, then postoperatively at 2 weeks, then 1 month, 2 months, and 3 months. Then in second test, which is the goniometer test, I performed the same test with the goniometer, and the which tells us about which gives the more accurate angle difference because of the goniometer. In third test, which is the threshold to detect passive motion test, the knee
5 minutes are over, Dr. Ashwini. Wrap it up.
Okay, sir, I would like to conclude faster, sir. In that third test, the time which is used, which time which is taken by a production of the angle was measured in the injured and normal knee of the same patient, and the follow-up was done at 2 weeks, 1 month, 2 months, and 3 months. This is the intraoperative photo which is showing the preserved tibial stump of the ACL. So my results were 25% of the patients were in the age group of 18 to 20 years, 25% were in the age group of 21 to 30 years, and 50% were greater than 30 years. 15% were, 85% of the patients were males. Locking was absent in all the patients, and instability was present in 100% of the patients. Leachman test was positive in all the patients, and MRI was consistent with the clinical findings.
Last
so in
30
the
seconds,
RPP test,
please wrap it up.
Yeah, in RPP test, as we can see in the graph, the normal knee is having 4 bars, which is showing the uninjured leg at 30, 50, 70, and 110-degree angles. But the preoperative score, the bar of the preoperative scores, they are the height is much the greater than the normal knee one, which is showing the angle difference or the overshooting knee of the injured side. It's showing the basically the knee injured knee, which is overshooting the uninjured knee. So the heights are more, but after the after the 3 months, the height of these bars are decreased, which is showing the angle difference is decreased. So the clinical improvement is there.
Dr. Ashwini concluded.
Yes, sir. Sir, I'm going for the conclusion. So in our study, all the patients who underwent into tibial stump preserving ACL reconstruction showed clinically and statistically significant improvement at 3 months follow-up, and there were no complications seen among patients who were included in the study. So my study concludes that stump preserving tibial stump preserving ACL reconstruction shows the postoperative proprioceptive improvement in the proprioceptive function. Thank you, sir.
Dr. Ashwini, the way you have presented by your mobile, it's very hard to read what you have written or what you are presenting. Don't you think? It's of no use of presenting now if the panelists are not able to see what you are presenting. I don't think so. Panelists must have read what you are presenting.
I could not probably read even a single slide, Dr. Ravi.
Yeah,
So
definitely,
I
sir.
cannot ask a question or cannot comment.
I don't know why he has presented from mobile, actually, just... so let us move to the next speaker, actually.
Yeah, next speaker.
Dr. Siddharth.
Yes, sir.
Just please share your PPT. His topic of presentation is outcomes in low-cost negative pressure wound therapy.
So, Sir, is my slide visible?
Not yet, dear. Share it again. If you have shared, then unshare it and from your side, and then share it again.
Sir, I think so.
You are using laptop now?
Yes, sir. I'm using a laptop actually, sir. I think some accessibility issue is there.
Is it a Mac?
Yes, sir.
Mac में देखो लेफ्ट साइड में ऊपर डेस्कटॉप की पिक्चर आई होगी जब तुमने शेयर किया होगा.
Sir, 1 second.
लेफ्ट कॉर्नर में देखो डेस्कटॉप लिखा हुआ आ रहा है. डेस्कटॉप 1.
Sir, 1 second, sir. Sir, desktop 1 आ रहा है actually.
डेस्कटॉप 1 को शेयर करो.
Sir, there's an accessibility issue. I need to recommend.
From the Zoom side?
Yes, sir.
Okay, fix it first. I am just allowing another one.
Yes, sir.
After
Yes,
that,
sir. Sorry, sir. Yes, sir.
Dr. Javeer, are you ready with your PPT?
Yes, sir.
Okay, please share it. His topic of presentation is analysis of acetabular cup positioning and functional outcome in total hip replacement. Put it on slide mode and then go ahead.
Yes, sir. Can you see the screen, sir?
Yeah, screen is visible, but put it on presentation mode and go ahead.
Okay, sir. Good evening, sir. My topic is analysis of acetabular.
Here, put it on presentation mode on the lower panel.
Yes, sir.
No, not this one, not this one. Right, move right. Yeah, this one, click it.
Okay, sir.
Move ahead.
Good evening, sir. Sir, my topic is analysis of acetabular cup positioning and functional outcome in total hip replacement. Introduction. Total hip replacement nowadays have become commonly performed reconstructive hip procedure for various hip disorders. Although total hip replacement THR is considered a very successful surgical intervention, a proportion of patients experience successful persistent pain or disability and or dissatisfaction with the outcome of surgery. Our aim is to determine whether post-operative radiographic variables are predictive of patient reported pain, function, and satisfaction after primary THR. Implant positioning is a major factor in post-operative outcome of THR. Implant malpositioning such as impingement of the neck of the cup may be a causative factor for dislocation, decreased range of motion, loosening, and polythene wear. Therefore, accurate positioning of implant is necessary to prevent impingement and long-term stability of implants. The optimum position of acetabular cup to be aimed during THR. Combined anteversion and inclination angle is major criteria for stability of THR. In this study, we will analyze the post-operative radiographic variables following THR and its correlation with functional outcome. Material and method. This retrospective study was conducted at ESI Hospital, Vasaidarapur, to analyze acetabular cup placement and functional outcome in THR. So total size is 30 hips and method of selection is 30 patients randomly compiled with our study without any dropout. Inclusion criteria, sir, OA hip, AVN of head of femur and fracture neck of femur with non-union. And exclusion criteria, complex limb deformity, fracture where bony landmarks cannot be identified or dysplastic hip. Sir, methods, clinical examination, all patients were assessed for functional outcome and acetabular cup positioning. Clinical examination at the latest follow-up was evaluated with Harris hip score. The corresponding hip score were entered against all the parameters mentioned in the hip score performa. And CT examination of acetabular cup by measuring the anteversion angle and inclination angle. Anteversion angles. Draw a first line connecting the center of two hips and a second line perpendicular to the first line and third line from the most anterior point of the acetabular cup component to its most posterior point. The angle between the second and third line is version of acetabulum. And CT examination of the cup in inclination angle. In acetabular inclination is measured by measuring the angle between line connecting the lateral and medial margins of the cup with transischial line drawn between the right and left ischial tuberosity. And sir, second, analysis of functional outcome by the Harris AFP score. Follow up, all these patients were called over phone to attend the OrthoPD. This study had been done to assess the post-operative acetabular cup positioning and functional outcome of total hip replacement, done for various indications. All patients were assessed post-operatively with CT scan of pelvis for cup version and inclination angle. These patients were also examined clinically to analyze the functional outcome based on Harris score. The results were compared and analyzed in these randomly selected patients, follow-up for 6 months. Observation and results. Number of and side of hips in our study, total 30 hips were analyzed. Among these, 15 hips from the right side and 15 from the left side. And sex distribution, total 30 patients were analyzed, 24 in male and 6 patients were females. Age distribution in our study, 5 patients were below the age of 30 years, 6 patients were the age group of 31 to 40 years, 7 patients in the age group of 41 to 50 years, and 12 patients were above the 50 years. In that case, in range of motion, on comparison of mean value of the range of motion, preoperative and postoperatively, hip are higher with the difference of statistically significant with p-value less than 0.001, sir. And pre-op flexion extension was the patient was 40 to 115 degree, and post-operatively the flexion extension was 80 to 130 degree. And same way adduction and abduction in pre-operatively 0 to 50 and post-operatively 25 to 60 degree. In internal rotation with external rotation, pre-op 0 to 40 degree and post-op 30 to 60 degree. And the total Harris his score, the mean Harris hip score was 85.23. Standard deviation 8.99 with scores ranging from 6. Yes, sir.
Your 5 minutes are over. Last minute, wrap it up.
Okay, sir. Thank you, sir. With score ranging from 63 to 93 of the 30 patients analyzed, 4 patients have poor outcome, 2 patients have fair outcome, and 11 patients with good outcome, and 13 patients have excellent outcome. Acetabular antiversion angle, the mean CT antiversion is 15.3 degree of the 30 patients analyzed with antiversion with on CT scan. Cup is retroverted in 1 patient, and 1 to 10 degree of antiversion in 2 patients, and 11 to 20 degree antiversion are 20 patients, and more than 20 degrees 77 patients. Acetabular inclination angle, the mean acetabular cup inclination angle was 42.7 degree. The cup inclination was 30 to 400 in 12 patients, sir, and 41 to 50 degree in 2 patients, sir. Complication. We had one case of dislocation with associated
last 30 seconds.
Okay, sir. Sciatic nerve neuropraxia due to retroverted acetabular cup, which were corrected by revision THR. Now the patient had recovered from nerve palsy and had good functional outcome. Limb length discrepancy, we had significant LLD of more than 3.2 centimeter in one cases. Other cases had around 1 centimeter shortening on operated limb. None of our patient had infection in our study. Interpretation. On comparison of the mean value of pre-op hip flexion extension range of motion, post-op hip flexion extension range of motion is mean value of post-op is 27.7 degree is statistically significant with a p-value of less than 0.001. In the same way, pre-op hip adduction abduction is 18.33, and post-op external rotation and internal rotation is 35 degree.
Dr. Javeer, concluded.
All value are less than 0.001. Discussions are, although total hip replacement is considered a very successful surgical intervention, a proportion of the patient experience present pain or disability or dissatisfaction with the outcome of surgery. In our study, we analyzed 30 cases of uncemented total hip arthroplasty who turned out for follow-up for
Dr. Javeer, concluded, please.
The post-operative radiographic variables were measured and they were statically analyzed with the modified Harris hip score. In most cases, restoring the original hip rotation center and strength target of 40 degree of inclination angle and 20 degree of antiversion will result in good clinical outcome. With a better understanding of the factors affecting optimum cup positioning, we can avoid impingement, dislocation, and minimize work in individual patients. From a clinical point of view, a safe zone to avoid hip dislocation has been defined between 40 degree plus minus 10 degree of cup inclination and 15 degree plus minus 10 degree as a version angle. In our study, average acetabular cup version is 15.3 and
Dr. Javeer, you are already out of 8 minutes.
in my study, sir.
Please.
Okay, sir.
Otherwise, I have to stop the presentation.
We used the modified CT. This method was most commonly followed in various studies. According value of this method is very high. About 95% all cases had acetabular cup inversion. So these are the in conclusion, in our study, 90% of patients had excellent functional outcome. 5% of patients had a good function and outcome, and 5% patients have a fair functional outcome. In our study, 90% of acetabular cup position were in acceptable range. Only 10% of acetabular cup were in excessive antiversion. These cases with excessive antiversion were not associated with dislocation of joint, but had no internal rotation. CT scan based acetabular cup measured has given good prediction on our intraoperative free head assessment of acetabular cup positioning. Okay, sir. Thank you, sir.
Thank you, Dr. Javeer.
Okay.
Atul sir, any questions?
Operatively in the lateral position, how do you were able to judge the inclination and all? Sir, the patient is in the lateral position. How do you perfectly judge this? I am asking about the acetabular part, acetabular cup positioning.
Sir, acetabular cup positioning in the after the post-op period, which is on the CT diagram. And all the studies done on the CT, both inclination angle and version angle, sir.
Because in the study, I couldn't find the correlation with your acetabular. In study, it was pre and post-operative. I was not able to find out anything regarding your main topic of acetabular cup positioning. I wanted something related with the acetabular, your findings as per your acetabular cup positioning in your cases. That was not coming out of your study, which was my concern.
Sir, we have initially started the best criteria in there are so many studies has been done. In that case, the 40 degree is around the 40 degree inclination and 15 degree version angle. So, sir, we start in both lateral approach and sir posterior approach, sir.
That is established. That is established what you are saying. What I am saying is in your study, you should have related your all the cases as acetabular positions and what complications or what positive points you found. That was not coming out of your presentation. That was my concern.
Dr. Javeer, what we are trying to tell you is कि आपकी स्टडी के अंदर अगर किसी पेशेंट का एंटीवर्जन 15 डिग्री है, तब भी हो सकता है कि आपके उसका आउटकम खराब आया हो, और ये भी पॉसिबल है कि कप का एंगल 25 डिग्री हो लेकिन उसका आउटकम अच्छा आया हो. So basically what we are trying to tell you is there is no criteria or a comparative thing in your study which can correlate your acetabular cup position with your clinical outcome. आप जैसे डिसलोकेशन की बात कर रहे हैं, डिसलोकेशन हमारा कंसर्न ही नहीं है इसके अंदर. जो लेवलिंग सेफ जोन की आप बात कर रहे हैं उसका कंसर्न ही नहीं आया इसके अंदर. You understand? So what you are trying to do, आपने अलग-अलग स्टडी से अलग-अलग चीज कट कॉपी पेस्ट की है. But the fact of the matter is you should have correlated your acetabular cup positioning with the Harris hip score clearly. वो तो कंपेयर ही नहीं हुआ आपका. You understand what we are saying?
Sir, in Harris hip score, sir, I mainly range of motion is taken, sir.
चला कि हो सकता है 20 डिग्री वाले के अंदर Harris hip score खराब हो और 25 वाले के अंदर बहुत अच्छा हो. वो तो पता ही नहीं चल रहा ना कहीं हमें. You understand?
सर mainly सर जो बेसिकली जो 40 डिग्री जो रेंज है सर, उसमें जो बेस्ट है 40 डिग्री के आसपास, सर उनका गुड आउटकम आया है.
That is different thing. And moreover, avascular necrosis is never inclusion criteria. It is arthritis of the hip.
Yes,
Avascular necrosis is what? Grade 1, grade 2, grade 3, grade 4, what? AVN is never an inclusion criteria. It is arthritis resulting from AVN. Chali, anyway, discussion is never ending. We can go on to the next candidate.
Thank you, sir. So our next speaker is Dr. Siddharth Pathak.
Yes,
His
sir.
topic of presentation: outcomes in low-cost negative pressure wound therapy. Dr. Siddharth.
Yes, sir.
Have you solved out your problem?
Yes, sir. Is my slide visible, sir?
Okay, it's visible. Go ahead, dear.
Yes, sir. Good evening, sir. My name is Siddharth Pathak. I'm a third-year postgraduate resident in UCMS and GTB Hospital. The topic for today's presentation is a change in the granulation tissue coverage and bacteriological load in an acute musculoskeletal wound after the application of a low-cost negative pressure wound therapy device.
Just click on the slide. It will move.
Yes, sir. Sir, negative pressure wound therapy has shown to significantly improve wounds for the past many years by various mechanisms, some of which are a decrease in the wound size, an improvement in the granulation tissue improvement, and a change in the bacteriological load, which is debatable, sir. In settings with limited resources, such as our hospitals in Delhi, government hospitals, simplified negative pressure wound dressing therapy is considered as an effective alternative. A low-cost negative pressure therapy is much more economical as compared to a conventional VAC therapy. There is scanty literature on the outcomes in wound care following the use of a low-cost negative pressure wound therapy. So the objective of my study was to evaluate the change in wound size as well as granulation tissue and bacteriological load pre and post application of a low-cost negative pressure wound therapy. So this was a prospective interventional study which was carried out in the Department of Orthopaedics, UCMS and GTB Hospital. The sample size was 21 patients. Patients of either sex above the age of 18 years with an acute musculoskeletal injury of less than 3 weeks were included. After surgical debridement, the negative pressure therapy was applied. Exclusion criteria included allergy to the curative components, a hemorrhage in the wound, any exposed bone divider periosteal coverage, any vessels or nerve exposed, or chronic osteomyelitis, as well as if the patient was on anticoagulants. After adequate surgical debridement, the negative pressure therapy was applied in the ward for a period of 48 hours. The device included a wall-mounted suction device, which is available in every ward, operated at a pressure of minus 125 millimeters of mercury, and a standard polyurethane foam, which is available at any hardware store we utilized after autoclaving. An adhesive drape such as an ioband was used, and a suction tubing was used. The sterile foam was applied directly on the wound and covered with the sterile adhesive drape. A suction tubing was attached to the foam, and the other end was attached to the wall-mounted device, which is operating at minus 125 millimeters of mercury. So this is the wall-mounted suction device which was used, and another example of a patient on which the dressing was applied. For evaluation of the wound size and granulation tissue, we used a overhead protection projector sheet, which is transparent, and we marked the grids on it pre and post. We measured the wound size as well as the granulation tissue. Similarly, microbiological sampling was done for this same wound pre and post application. So there was a result of 100% decrease in wound size in all of the patients. The mean reduction in wound size was approximately 599.2 millimeters squares, which was found to be statistically significant. So the granulation tissue coverage was also found to increase in all the 21 patients. And the mean increase in granulation tissue was 716 millimeters square, which was also found to be statistically significant, sir. So this is an example of a pre and post wound while we measure it on the OHP sheet, as well as the granulation tissue. So this is an example of the same wound which was sequentially followed up, and within a period of 1.5 months, we could achieve a lot of closure in the wound, sir. When coming to the bacteriological load, sir, in 13 out of 21 patients, there was a decrease in the bacteriological count after the application of negative pressure therapy, but there was an increase in 8 of the patients. So the overall increase in the bacteriological count was not found to be statistically significant. In conclusion, sir, I would like to conclude that although our study utilized a low-cost negative pressure therapy, it showed a comparable significant increase in the granulation tissue and a significant decrease in the wound size. Sir, when compared to other studies utilizing the VAC system, the cost of each dressing was significantly lower, as the conventional VAC system is really expensive. The assessment of bacteriological clearance showed a non-significant decrease in the bacteriological clearance from the wound, suggesting that the beneficial effects of VAC cannot be attributed to an increased bacteriological clearance. That means, sir, the effects of VAC cannot be attributed whether it is due to the clearance of bacteria or not. So these parameters were found to be comparable to other studies which utilized a conventional VAC therapy. Sir. Thank you.
Thanks, Dr. Siddharth. Atul sir, any questions?
Siddharth, what was the average stay of the patient for this therapy which you were doing?
So we applied the therapy for 48 hours. We took a standard of 48 hours pre and then removed the VAC and then measured these parameters.
Only 48
hours? Yes, sir. Sir, if few of the patients we applied sequential VACs, but parameters were not judged, but pictographic evidence was taken for those patients, around 2-3 patients.
In these 2 days, it was significant.
Sir, decrease in wound size and increase in granulation tissue was significant. Yes, sir.
Dr. Siddharth.
Yes.
First of all, I am quite impressed at seeing the p-value of 0.000.
Yes, sir.
Because statistically, I have never come across with such a value in any statistical study.
Yes, sir.
So I don't know what is the significance of 0.000.
Sir, it basically denotes that the digit which has come after the 3 decimal points. So that is why they show it as 0.00 as a convention.
Yeah, so that's quite statistically significant. But I just, anyways, a polyurethane foam. You could autoclave the polyurethane foam?
Yes, sir.
Is it autoclavable?
Sir, we used to wrap it in a normal sheet which we send normal implants also. Yes, sir, it used to be autoclavable.
Foam is not autoclavable, I think. Can it sustain temperatures of 121 degrees centigrades?
Sir, there were studies which had done the same, and we could also achieve the same, sir. We used it regularly. Sir?
You used the same quality of foam, same foam?
For all patients, yes, sir.
And I think one of the biggest concern which I see here is continuous suction. So do you think continuous suction on wounds is recommended in any of the study? Or sir, because VACs are intermittents?
Sir, we used to keep those as parameters in which the exudate dropped to a value of less than 30 ml. We used to stop back and we did not include those patients in our studies. We applied these on a lot of patients, sir.
See, I think honestly I'll tell you, the exudates will not stop. The continuous suction will suck out the normal interstitial tissue also. And it will deprive your patients of proteins.
Hypoproteinemia.
So that is one thing you should just read about it, continuous versus intermittent suctions. Yes, there are quite a number of studies available online. But
yes,
all in all, a good study. Thank you.
Thank you so much, sir.
Thank you, Dr. Siddharth. Thank you, sir.
Thank
so
you so
our
much,
next
sir.
speaker is Dr. Sudeep. Dr. Sandesh. Dr. Sandesh, please share your PPT.
Is it visible, sir?
Not yet. Share your PPT, please.
Shared.
You have not shared the PPT. You have just shared your basically desktop. Open your PPT. Open it.
Okay, I share screen.
No, your screen is not coming. Open the PPT.
I open. Is it coming, sir?
No, not yet.
I did, sir. Like.
Not yet.
Okay, I'll try one more time. Share screen. Where it went? Missing. So you take the next contestant, please. I'll.
Okay. So our next presenter is Dr. Swaradip Mitra. Dr. Swaradip Mitra, are you there? Dr. Mitra?
Yes, sir. Yes, sir.
Are you ready with your PPT?
Yes, sir. Yes, sir.
Please share.
Visible, sir? Sir, is it visible?
Yes, go ahead.
Okay. Good evening, sir. Today, my topic is comparison between single spin and double spin intra-articular PRP injection in patients with bilateral early osteoarthritis knee, a novel technique. Now, osteoarthritis knee is the most common type of arthritis in both developed and developing countries. It is a chronic progressive musculoskeletal disorder characterized by gradual destruction of cartilage in joints. Now, it is more common in women than men. 45% of 45% of women over the age of 65 years have symptoms, while 70% of those over 65 years show radiological evidence of osteoarthritis. Now, by 2050, people aged over 60 will account for osteoarthritis more than 20% of the world's population. Treatment of ONE is difficult due to the avascular and anural nature of adult knee cartilage, which results in a low regenerative capacity and thus limited healing potential for the joints. The joint destruction arising from osteoarthritis occurs as a result of an imbalance in the equilibrium between the breakdown and repair of the joint tissue, while a combination of the cellular changes and biomechanical stresses causes several secondary changes in the joint. Now, recent research has identified a number of key biochemical pathways that could be targeted therapeutically through biological intervention. PRP, that is platelet-rich plasma, is one such intervention. PRP is defined as an autologous plasma suspension of platelets characterized by a platelet concentration higher than in blood and able to release growth factors involved in reparative and regenerative processes. Now, it is a simple and minimally invasive method to obtain a high concentrated or autologous growth factors in physiological proportions, which can be easily and safely placed directly into the lesion site. Moreover, the risk of allergy or infection is negligible due to the autologous nature of the platelet extract. Now, from my study, some authors suggest that PRP platelet concentration should be at least 2 times the whole blood platelet concentration. However, concentrations up to 8 times that of blood levels have also been reported with good results. Single spinning centrifugation results in platelets up to 3 times that of a baseline level, whereas double spinning centrifugation results in platelets up to 8 times the baseline level with a high leukocyte content. However, there are very few studies which compare the use of the two techniques of preparation of PRP in early osteoarthritis knee. Now, the aim of the study is to explore the treatment of degenerative lesions of articular cartilage and osteoarthritis by comparing the two products, that is single versus double spinning, on a patient with bilateral ONE. Now, I used the VAS Oxford knee score and the WOMAC score at the end of the first, third, and sixth month. It is a randomized controlled trial, and inclusion criteria was patients aged between 40 and 70 years, and patients were clinically and radiographically diagnosed as Kellgren and Lawrence grade 1 and 2 primary osteoarthritis knee with no improvement in conservative management, that is activity modification, weight loss, physical therapy, or NSAIDs. Exclusion criteria was if there's any previous lower extremity surgery, poor diabetic control with HbA1c more than 7%, rheumatoid arthritis and gout, history of infection or current infection of the affected joint, hematological diseases with bleeding diastasis, hemophilia, and any documented anemia. Now, a total of 32 patients were selected for the study, and investigations such as X-rays of bilateral knee, AP, and lateral view in the standing position was done. Functional outcome was then measured using the WOMAC Oxford knee score, and the pain was measured using the VAS scores. Now, the single spinning technique was obtained by first a 36 ml of venous blood sample was collected in 4 tubes and then centrifuged at 1500 RPM for 15 minutes, obtaining a concentration suspended in plasma that was extracted by pipetting carefully to avoid leukocyte aspiration. Then 10% of calcium chloride was added to activate the platelets, and then for the final PRP extract was used for injection using a 10 ml syringe. Now, using the single spin technique, we found that the platelet concentration was around 4 times higher than the normal platelet count. Now, in the double spinning technique, we drew 150 ml of whole blood in a double bag, having 63 ml of citrate phosphate dextroadenine. Now, the 2 centrifugations were done. First at 1,800 RPM for 15 minutes, and then at 3,500 RPM for 10 minutes to concentrate the platelets. Now, the amount of PRP that was obtained after this was around 15 to 20 ml, and then the platelet concentration was we found was around 8 times higher than the normal platelet count of that of the patient. Now, this is the centrifuge that we used. This is the PRP that we had obtained, and the injection was applied on the superior lateral aspect of the knee, with the knee in around 60 degrees of flexion, as you can see here. Now, these are the WOMAC. This is the WOMAC score that was used. This is the VAS score that was used, and also the Oxford knee score that was used. Which these are all questions based on activities of daily living. Now, the results were from what we noticed is that grade 2 ONE was more predominant in our study than the grade 1 ONE, and both male and female, we got 16 patients each. And as you can see here, with patients who were less than 50 years, were a greater concentration than the patients who were more than 60 years. Now, if you look at both the techniques, that is single spin PRP and also double spin PRP, the statistical analysis was there was if you look at the VAS scores, there's a reduction of VAS scores which is statistically significant in both the groups. However, if you look at the double spin PRP, we received much lower scores of VAS at 6 months follow-up. As you can see, at 6 months follow-up, the mean came down from 7.94 to 4 in single spin, and double spin came down from 8 to 3.25. Similarly, in WOMAC score, lower scores were also obtained in the double spin PRP group. As you can see here, the mean for the single spin reduced from 77 to 54.91 after 6 months, and for the double spin from 74.84 to almost 43 at 6 months.
Dr. Mitra, your 5 minutes are over.
Yes, sir. And the Oxford knee score, an increase in the Oxford, greater increase of the Oxford knee score was seen in the double spin PRP group, as you can see here. Now, after an interval of 6 months, it was seen that the knees which received the double spin PRP showed greater reduction in VAS and WOMAC scores and better increase in the Oxford knee scores. Now, although there was more pain and swelling in the knees with double spin PRP due to the high leukocyte concentration compared to the single spin, better end results were obtained using the double spin technique. The limitations were this is a very short duration of follow-up, that is 6 months, and there are very few articles which actually compare the two, that is single spin versus double spinning method. So further research is required in this topic. Thank you, sir.
Thanks, Dr. Mitra. Can you unshare your screen, please?
Yeah.
Atul sir, any questions?
Any difference in the adverse effects of single spin and double spin you found in the cases? Like you said, pain was more, swelling was more.
Yes,
so
sir.
how much period it was for the double spin?
So actually, because of the double spin, the amount of leukocytes, that is the leukocytes had also increased with the platelets. So immediately after injection, the patients did complain of more post-injections pain and as well as swelling. But that itself reduced maybe after 4 to 5 days, even after NSAIDs. But that after the initial pain, the overall reduction of pain even after first, third, and 6th month was greater than that we saw in the single spin technique.
Dr. Mitra, what was your final conclusion? Why is it so that your double spin PRP gave better clinical results?
So, according to literature, it says that because of the greater concentration of the platelets that we got, that is almost 8 times more than the normal amount. That may be one of the reasons why there was a marginal increase. Although both were significant, there was a marginal improvement. Greater improvement in the double spin technique than the single spin.
Are your patients blinded?
Yes, sir. Yes, sir.
Did you mention it earlier?
I haven't mentioned, but they were blinded. So yes, sir.
You did not know? You did not mention?
Sir.
You did not mention they were blinded?
No.
And moreover, I think just a small suggestion. You should never label and name your studies as randomized controlled trials.
Yes, sir. Okay.
Because if you label as trials, you will fall into deep problems getting it approved from boards and trial boards.
Right. Yes.
Lots of official problems.
Yes.
They'll be better named as randomized controlled studies.
Yes.
Yeah.
Okay.
Fine. We can go to the next candidate.
Okay. Thank you, sir. Thank you. So, Dr. Sandesh, are you ready with your PPT?
I'm ready.
Please share it.
I'll try to. No, not this.
It's still the same problem. Just open your PPT on the desktop.
Yes,
and then
sir.
share it. Okay?
I opened in my desktop, sir.
Just unshare it first.
Okay.
First unshare yourself.
Okay, 1 second.
First unshare it.
Actually, you have to share the window in which your PowerPoint is open.
Yes, sir.
Yeah, and we can see the window. Where is it open? Close every window, then you start this.
I am unsharing your presentation. Now open it on your desktop.
Okay, so
have you opened it?
I opened in my desktop, sir.
Okay, it's open.
Okay.
Yes, sir.
Now just share it.
Okay, now I will share. Yeah, came, sir. It's visible, sir.
Yeah.
I'll make full screen.
Put it on presentation mode.
It's visible, sir.
Yeah, go ahead.
Very good evening to one and all. Today, myself, Dr. Sandesh Agarwal, I'll be presenting my oral presentation on to evaluate the radiological outcome of distal third tibia fracture treated with intramedullary nailing using close reduction internal fixation technique versus locking compression plate using minimal invasive plate osteosynthesis technique, that is MIPO technique, a retrospective study. So under the guidance of Dr. Prabhuhi, Dr. Sagar V. Introduction. Distal tibia fracture are challenging injuries because of their inherent instability, soft tissue, subcutaneous nature, and poor vascularity of the bone. It accounts for approximately 7% of the all tibia fracture and less than 10% of all lower extremity fracture. The best treatment still remains controversial. Intramedullary tip locking nail or the expert tibia nail can be considered as the gold standard, but there are concerns regarding biochemical stability of fixation because of the risk of malunion or non-union in distal tibia fracture. The intramedullary nailing spares the extraosseous blood supply, avoids extensive soft tissue dissection, while the MIPO technique, it tends to reduce the iatrogenic soft tissue injury and damage to bone vascularity, as well as preserving the osteogenic fracture hematoma. What is the aim and objective? Aim is to evaluate the radiological outcome of distal third tibia fracture treated by intramedullary nailing using close reduction internal fixation technique versus locking compression plate using MIPO technique. Methodology. In this retrospective study, 36 patients with distal third tibia fracture were treated in a hospital, that is SDUMC, were from December 2016 to 2019 were studied. 16 cases of the distal third tibia fracture who underwent intramedullary interlocking nailing, that is tip locking, using close reduction internal fixation technique, while 16 patients underwent locking compression plating by MIPO technique. They were included in the study. Radiological outcome was assessed at 1 month, 3 months, 6 months on the radiograph. On the basis of the callus formation, at least there would be callus formation in the 3 cortices. So what is the methodology? This is like inclusion criteria: patient of age group above 18 years with distal third tibia fracture and all extra-articular closed fracture of distal third up to 443 A3 of AO classification. Exclusion criteria were pathological fracture, patient treated conservatively or any other method for other medical reasons, compartment syndrome, poor local skin condition, associated neurovascular injury. So this is actually the heart of the presentation, which will depict everything. So in a study, the gender distribution, male and female. So out of 32 patients, 13 were male, and out of which 13 underwent intramedullary interlocking nailing, while 12 underwent locking compression plating. While among the female, 3 underwent intramedullary interlocking nailing and 4 locking compression plating. So these were the sides, left and right side, and the associated fracture that you can see in the screen, the treatment and the associated treatment. For the associated fracture was a treatment, was the rush pin, semitubular plating, and the union time noted that were 16, 17, 18, 19, 20, 21, 20, 23 weeks. So this will suggest you which all patient, and the complication associated. So the result in a group A, MIPO technique receiving the intervention of locking compression plating has a higher duration of union time compared to the group B, that is a close reduction internal fixation technique receiving the tip locking intramedullary nailing, and this difference was statistically significant with a p-value of less than 0.05%. The union time noted in the tip locking nailing was 17.25 plus minus 1.065, and in the LCP group it was 20 weeks 0.9 plus minus 1.759. Discussion. Distal third tibia fracture remain one of the most substantial therapeutic challenge that confronts the orthopedic traumatology. Distal third tibia fracture with articular involvement may be a very arduous task. This type of injury often creates a predicament for the surgeon. The difficult decision lie in which fixation option which creates the most structural stable environment along with the best return of function, keeping in mind and minimizing risk of complication. Though conservative management for these fracture has been described, this method has been largely superseded by operative technique for displaced or irreducible fracture, and this and the fracture with intra-articular extension. Mean union time for the fracture treated with MIPO technique was 15.2 weeks. By the study by O.W. et al., that was 24 weeks. In the study by Ronga et al. And Bong T. Il et al. And 22 weeks by Someshwar et al., the mean time of union in our study was 20.19 week. Deep infection was seen in 1 patient. Superficial infection was seen in 3 patients in a plating group. In a study by Devil Gapu et al., while deep infection was seen in 2 patients, and by a study by Aaron M. et al., Gu J. et al. Has reported 6% of the case has deep infection in the MIPO plating, while our study has 6.3%, just a 1 patient with the infection, and 1 patient with a superficial infection and 2 patients with a deep infection in the MIPO plating. Anup et al. Investigated 42 patients, in which 21 patients underwent intramedullary interlocking nailing and 21 patients underwent MIPO plating technique. Average union time noted was 18.26 week in IMI nailing group, while 21.70 weeks in MIPO technique group. Partial weight bearing and full weight bearing average time noted was 4.9 week and 10.09 week in the IMI nailing group, while 6.09 week and 13.38 week for MIPO plating. That's a partial and full weight bearing.
Your 5 minutes are over, Dr. Sandesh.
Okay, so I would like to share my cases. So this is case 3, which is presented with the distal tibia, distal tibia and fibula fracture, for which tip locking, intramedullary interlocking nailing was done, and semitibular locking plate for the associated fibula fracture, and the union was achieved within the 17 weeks. This is a case 11, which will suggest you a distal tibia fracture, distal tibia and fibula fracture, in which again the tip locking nailing was done and the associated fracture was treated with a locking plate. This is a case 13 that will suggest distal tibia fracture, both bone fracture, and that was treated with the plating. This is a case 23 in which the long plate was used. This is case 29. And I would like to conclude that MIPO technique using LCB plate is reliable. It's a reliable approach towards a distal tibia fracture that is not suitable for the intramedullary nailing, such as fracture with a small distal metaphyseal fragment with a vertical split with a marked comminuted fracture, and in fracture with intra-articular extension. Soft tissue complication, malalignment, and knee irritation problem that can be avoided with this. So these are my bibliography, and I would like to acknowledge these personalities. Thank you.
Thank you, Dr. Sandesh. Atul sir, any questions?
Your inclusion criteria had only extra-articular distal third tibia, whereas in your conclusion, you said that interlocking nailing versus plating. And so plating is better in those which are going in intra-articular and all. So I think your cases also showed only distal third, where the fragment of the distal third is quite big enough, in which your nailing or plating both can be done.
Yes, sir.
Your conclusion does not show your inclusion criteria for your study. I don't
know. Jatin sir?
Dr. Sandesh.
Yes, sir.
This was a retrospective study, right?
Yeah, yes, sir.
That means the patients are already operated.
Yes,
and they already were by the time you started your study, correct?
Correct, sir.
So how could you decide initially that in what patient would you do nailing, in what patient would you do plating?
That I randomly selected, sir. I actually collected a data for around 60-70 patients, and in which I can find out the follow-ups complete. I took that.
No. It is not about the random selection of data in retrospective. It is a random selection of patients while you were to operate. There is a very, very strong bias. I don't think your study design is valid for comparison of 2 standard modalities like plating and nailing. Dr. Atul, would you agree with that?
Yeah, I agree with you.
You did not select your patient properly. You have selected randomly, but you have not selected your patient randomly while you were to operate them. It is probably by the surgeon's choice that yes, today I will do nailing in this case, Today I will do, this is comminuted distal tibia, I will do plating here. So that's, you cannot compare results of these two modalities, sorry.
And even we don't have anything at the end result of these cases, because
Nothing at all, yeah.
the end result has to be seen. Now, then only you can compare. Otherwise, there is no point.
Absolutely. Initially, you were supposed to randomize your patients into two groups.
Yes, sir.
Where the surgeon was blinded that, yes, I don't know what I will do today. The fracture might be comminuted, but I will do a nailing.
Nailing.
Okay, and the fracture might be absolutely good two-part, I'll do plating. Then you are able to compare, because many times a bad fracture will fall into category of nailing and a simple will fall into plating. Then you are able to compare, no, how effective is your method of operation. So I would say you probably need to randomize, but anyways, these are endless things. Thanks for your presentation.
Thank you, sir.
Thank you, sir. Our last speaker is Dr. Sudeep.
Yes.
Dr. Sudeep, please share your presentation.
Yes, sir. Sir, is it visible, sir?
Yeah, it's visible. Please put it on presentation mode and go ahead, please.
Yes, sir. Good evening, sir. I'm Dr. Sudeep. I'm an assistant professor in the PS Medical College in Kuppam. I'm going to talk about a study where we are comparing the efficacy of peroneus brevis versus flexor hallucis longus in the repair of the insertional tear of tendoachilles rupture, sir. So acute tendoachilles tendon injuries has been reported. It is quite common nowadays. It is seen because of more sporting activity in the individuals, and it accounts for almost 40% of all tendon ruptures, partial or complete. And this is seen quite commonly now. So the treatment for acute ruptures are different from delayed ruptures. In acute ruptures, you can there is a role for conservative management. There is percutaneous suture management, and also there is open surgical repair. Okay, and for delayed tendon transfers can be considered, and other methods like turn down plasty also can be considered. So the choice is basically dictated by the delay in presentation of these patients and the surgical expertise and the condition of the tendon at presentation. So previously there was a hypothesis where turn down flap included turn down flap and the repair for the TA tear along with plantaris tendon augmentation was compared with just simple end-to-end repair with augmented plantaris tendon was done, and it was said that these two groups are the same. But in our study, we dealt with the cases which were where the tendoachilles were ruptured from the insertion. So in this case, you cannot do a turn-on plasty or plantaris augmentation. Here, the only available options were tendon augmentation with flexor hallucis longus or peroneus brevis or peroneus longus, and or another option is to use suture anchors directly in the shaved off calcaneum and bring the Achilles tendon down and suture it. But this is a relatively costlier option, and in our setup, it was not possible. So the aim of the study was to compare peroneus brevis and flexor hallucis longus in the augmentation in the insertional TA tear. So we wanted to see whether the functional outcome of one was superior to the other. So the study was conducted in PS Institute of Medical Sciences in Kuppam, Andhra Pradesh. The patients had a clinical examination done, and we got modalities as X-ray and ultrasound was done pre-op. And then after the surgery, the follow-up was at 3 and 6 months, and the scoring that was used was RUP score and AOFA score. So the inclusion criteria were all patients with insertional TA tear above 18 years, and those with other fractures around the ankle like calcaneal fractures were excluded, and any other previous surgery of the tendoachilles was excluded. So the procedure that was used, first we chose all these cases which came into the inclusion criteria, And then we did a systematic random sampling where the surgeon and the patient both were blinded. And the third person, who was the investigator, he was the one who gave the chits to each of the patient groups. So these are some cases. One case where we have used the flexor hallucis longus. You can see clinical photos here where the TA tear is seen on one limb. Okay, the X-ray is relatively normal, but here for the flexor hallucis longus, we using the posterior approach, we can see the flexor hallucis tendon through the approach itself deeper to the TA tear, and so after plantar flexing the ankle, we get sufficient length and we harvest the tendon. Here the FHL is taken through the insertional TA tear, through the remainder of the tendon, and it is anchored in the calcaneum using an interference screw and pull-out sutures. So this is the follow-up post-op clinical. This is another case where peroneus longus tendon was used. Here also, this was a relatively older case where the tendon had ruptured and there was retraction of the tendon. And for this patient, we had to use VY lengthening as well. And we have used another small incision to harvest the peroneus brevis, and fish mouth repair was done and anchoring into the calcaneum. This patient went on to have wound complications and then again had a rotation plastic surgery, and then the patient recovered. So the assessment was done using the RUP score and the American Orthopaedic Foot and Ankle Society scores. So the follow-up of these patients were done from 3 months at 3 months and 6 months, and using both of these scores. The data analysis and interpretation was, we used a software and Excel sheets, and we fed it into the software, the Stata 14.1, and p-value of 0.05 was considered significant, and less than 0.01 was highly significant. So the patient demographics, female patients were only 44%, males were slightly higher. And this was one of the conclusions that we were drawing, where the left side was injured more than the right side. The reason I'll tell later. Amongst these patients, majority had no complications. 2 patients from the FHL group had surgical site infection, and 3 patients from the peroneus brevis group. Also, there was scar tenderness in the peroneus brevis group patients. So the RUP score, excellent score, was seen in few, and most of the patients had good score, whereas very few patients had a fair score because of these wound complications mainly. And the similar scenario was seen with AOAFS score, where majority were good and excellent, and few patients had a fair and poor outcome. So the discussion, we took up this study to see the efficacy of flexor hallucis longus versus the peroneus brevis tendon augmentation of insertional tendinoachilles tear. So in our study, the Achilles tendon ruptures was seen at the mean age of 36 years, and incidence in men in our study were more common than women. And these observations were similar to another study by Lemmy et al. Okay. And in our study also, we had the left side that was more common. This is because this was consistent with another study by Chang et al., where they have showed that the left foot in a right dominant person, the left foot has more push off. So the chances of injuring the TA tendon on the left side is more due to degeneration more on that side. So in the complication, 3 patients in the peroneus brevis group developed surgical site infection. One of them, which I showed, required flap coverage. One required only surgical debridement and secondary suturing, and that patient went on to do well. And one healed with only intravenous antibiotics. Other than these, 2 other patients had scar tenderness. In the FHL group, there was surgical site infection for 2 patients, but both of these patients recovered with regular antibiotic coverage. At 6 months, we could follow up only 24 cases of FHL and 21 cases in the peroneus brevis group. using both of these scorings, and it showed that relatively both the groups had equal results. So to conclude, in our study, we do not find any statistically significant difference between the two groups, but still there are a few patients that we are still trying to follow up. Because of this pandemic, we could not access all of those patients, but we will add more and more results. And both the flexor hallucis longus as well as the peroneus brevis are good methods with predictable outcome rates. But what we suggest is considering flexor hallucis longus is better because it can be accessed through the same incision. You don't need a separate incision of the fifth metatarsal base, and it is more in line with the Achilles tendon. So that is another advantage, and also it has theoretical advantages of improved vascularity at the tendon repair site. So these are the references. Thank you very much.
Thanks, Dr. Sudeep, for a nice paper. Atul, sir?
Any functional difference in that too?
Functionally, that's what, sir. When we did the scoring for both these groups, there was not much of difference, sir.
And the complications was not due to the different augmented tissues. This complication can be as because of the repair itself. You had separately said it is not related to your complication rate in one is more than other. It is not like that. It is because of the basic procedure. It is the wound complications are known in this procedure. So
Yes, sir.
There is
Complications can be there in both the groups. Yes. Yes, sir. Yes, sir.
Was there any loss of eversion in the peroneus brevis group? Did the patient walk with slight inversion?
Not that we could notice any, sir.
That is quite seeable, common. Did you give a incision distally also on the first metatarsal to harvest the FHL till the knot of Henry, or just to quite form the tendon?
No, sir. What we did is through the same approach, we did not use any extra incision. Maximally plantar flex the ankle and pull the tendon, and how much ever length we could harvest through the same incisions.
Did you do any objective strength measurement in the post-op of the two groups?
Strength measurement, no, sir. We could not do, sir. That it requires some dynamometer and all those things, sir. We don't have that clear.
Yeah, you should have done that to give power to your study.
Yes, sir. We'll try to get those, sir.
Okay, Dr. Jatin, you want to ask something?
I think you already asked my part.
Thank you, sir. Thank you, sir. Actually, we are really thankful to Dr. Atul Vaid sir and Dr. Jatin Talwar sir for sparing their valuable time. Now, I would like to invite Dr. Dhananjay sir. Dhananjay sir, are you online? Dr. Dhananjay sir and Dr. Hitesh Lal sir, just to conclude our session actually. It was a lengthy and just...
Dhananjay is there or not? Yeah.
Dhananjay sir is...
Yeah, I would like to thank the panelists, Dr. Atul Vaid and Dr. Jatin, for sparing the time for this free paper session. And every PG has to start some time in his life to present the talk, and this is the best time. And we know the thesis of PGs are for 6 months duration. Follow-up is usually for 6 month duration, so don't worry. This was the main critical comment you got.
Speech presentation. Thank you from Delhi Orthopaedic Association, the panelists and the speakers.
Thanks a lot, Dr. Hitesh, for inviting us. Thank you.
Thanks, Hitesh, and thanks, Rajesh, as well as thank you so much.
Thank you, sir.
Ravi.
Thank you.
Good night, Dr. Atul. Good night, Dr. Hitesh. Good night, Dr. Ravi. Thanks a lot. Thank you.
Thank you, sir.
So much.
Dr. Amit Kansal, are you there? Dr. Amit? Thanks, Dr. Rajesh, for sparing 4 hours. sitting with me.
Thank you, sir.
Thank you all, PGs. Ashok sir, are you there? Ashok sir? सब लोग ऑफलाइन है.
No problem, sir.
एक्चुअली सेशन एंड करते हैं.
जी सर.
अशोक सर. Yeah, Dhananjay sir is there now. Dhananjay sir.
Hi.
Sir, welcome.
Thank you so much. Are we finished?
Yeah, sir. We
Wonderful.
finished. Just waiting for your
Guys,
conclusion.
let me thank all of you. I think you did commendably well. I really appreciate the way all the presenters, they were grilled, the questions were asked. I mean, you were not just invited to come here and make your presentation. The way their presentation was scrutinized, I think they must have learned a lot, and that was the basic idea of this presentation. I'm really thrilled. Thank you so much for all your support, all your hard work, all the time, and the passion, of course, which you guys showed. Thank you so much, really. Thank you.
Thank you. Thank you so much. Just let me call Ashok sir to end the session.
Mm-hmm. So do we have hall B tomorrow or not?
Sir, no.
No. Okay, fair enough. No
कल
problem.
हमें जरूरत पड़ेगी सर हॉल बी की. I don't think so.
I think how many papers have been done in hall A and hall B combined together?
Sir, today. Sir, I'm not aware of hall B actually. In hall A, we have just completed around more than 20 presenters today.
More than 20.
Yeah, sir.
Because I think we had 43.
Yeah, we had 43, sir.
And we had to accommodate almost 8 to 10 people more.
In tomorrow, sir?
No, today. I mean, those people, those who were left out or didn't receive the call or whose name were not here in the list, there were at least 4 which were adjusted here.
Yeah,
and
sir.
3 in hall B. So 7 people.
In
That
session
makes it 50.
In session 2, I have adjusted 4 people. And around 3 or 4 people in the hall B.
So 8 people. So that means if there are more, see, the only problem is if the guys, those whose abstracts were accepted, and if they call me up tomorrow, that's why you have to give me certificate, then I will be in a fix. Because if you don't present, you don't get the certificate. Mere acceptance of the abstract doesn't qualify you to, become the presenter.
Definitely.
So that's why I was wondering if you can take out some time. If all those guys approach me, then what should be our plan of action then?
Sir, we can just
adjust them somewhere in the evening then, or we can simply create a Zoom link, some Zoom meeting or Google meeting or something like that.
Take a Zoom link
Independently from this particular session, right?
Even in between, sir, we can spare the time because maybe some of the presenters may not come tomorrow out of the listed ones.
Yeah.
Should I stop the stream?